inspired us to have a CME during this unprecedented times. It is my pleasure and privilege to invite everyone to the CME on behalf of MGM University of Health Sciences and MGM New Bombay Hospital. I welcome all the eminent speakers, the moderators, and the organizers for kindly agreeing to be a part of the CME and show willingness to share their knowledge and vast experience. I sincerely thank you on behalf of the MGM Group. I also extend a very warm welcome to our audience who have taken out time to engage in the CME. We are having more than 600 registrations at this juncture. I promise to you that this CME will be very informative, thought-provoking, and leave you richer in knowledge because of our exemplary speakers. To begin the conference, I would like to request Dr. Nitin Kadam sir, who is the Pro Vice Chancellor of MGM University of Health Sciences and also the Director of MGM New Bombay Hospital, Vashi, to address this gathering.
Thank you very much, Dr. Divyashree, and good evening, everyone. On behalf of MGM Institute of Health Sciences and MGM New Bombay Hospital, it gives me a great pleasure to welcome you all today for this CME. As we all are aware that India detected first COVID case on 30th January 2020, and today we have around 16.2 million cases and 1.86 lakhs deaths as on 24th of April. Global figures are also very scary. It's a 146 million cases and 3.06 million deaths. This shows how fast and how far the virus is spreading. All of us are aware, and so after 1 year, we thought it's time to interact with our colleagues and learn from their experiences and share our experiences with them. Last year, we were able to manage the first wave comparatively better. In the initial months, all were busy organizing the healthcare system to deal with the pandemic, including ramping of the testing, training and maintenance of the human resources, maintenance of the supply chain of PPE and other hospital supplies. At MGM also, we started around 1,000 beds of dedicated COVID hospitals in 3 districts of the Maharashtra, out of which 200 beds are critical care beds. As the time went, I think, gradually after understanding the pathophysiology of the disease and with the availability of information of global experiences, we were able to prepare common protocols for clinical care, and that helped to reduce mortality to a great extent. Until now, protocols have been constantly evolving and changing. Initially, it started with the prophylactic use of hydroxychloroquine, followed by use of convalescent plasma, and there are so many things we tried. And now we may be able to zero down the pharmaceutical interventions to steroids, anticoagulants, remdesivir, and immunomodulators as per the stage and as per the selected cases. If we see towards the end of first wave, that is somewhere on the 2nd February 2021, we were at 8,600 cases per day. Deaths were less than 100 per day, and the test positivity rate was 2.8%. At juncture, the vaccination had also started. The statistics were better, and unfortunately, the complacency set in, and that's the problem. We thought perhaps we have overcome the pandemic, we have controlled the pandemic, and at that point, second wave hit in the country. And this is the same time somewhere I remember the words of Dr. Raman Gangakhedkar. Somewhere in the 2nd week of February, he said We'll have to be more cautious. We'll have to increase our non-pharmaceutical interventions. Otherwise, if second wave comes, it will be difficult for us to organize the things. And today, we are 332,000 cases per day. Deaths are more than 2,000 per day. And our test positivity rate is increased to 20.2%. And in some of the focus areas of Maharashtra and Bombay, it has reached up to the 25%. This second wave looks different from first wave, as the ineffectivity is more and the rate of increase in cases is almost double. The younger population is getting affected more. Parallelly, we are also having to deal with the COVID sequelae. More people are needing oxygen respiratory support, and this time, and in terms of reduction of the supplies, there's shortage of ICU beds, there's shortage of medicines, and even there's shortage of oxygen at this peak of the second wave. Previously, it was mostly the shortage of the PPEs during the first wave. Initially, the second wave looked like a geographical cluster, but now in the third week of it has spread to all the states. To cope with this huge number, we have to break the chain of transmission of the viruses and reduce new cases. At this time, we feel the only tool in our hand is a mass vaccination, which may be a game changer. But there are so many challenges also. The major challenge is a vaccine hesitancy, and it can be reduced by providing transparent information about the safety of the vaccine and the transparent report of the adverse events. There's also need to keep up even increased non-pharmaceutical interventions like masking, social distancing, hand washing, and avoid gathering. Though these things look very simple, but these are very, very important as it reduces the transmission as well as probably it will reduce the mutations also. There's another most important aspect. The worst part of the pandemic will begin if pandemic fatigue sets among the healthcare workers and institutions. They have been working at their highest capacity for over a year now. So preservation of their morale is just important. I'm sure all of us, we have many questions and many suggestions also. And this is the reason we gathered here to discuss and deliberate upon COVID-19 insights in presence of eminent and accomplished doctors across the medical and healthcare space, including some of the from the most prestigious institutions like ICMR, CMC Vellore, Hinduja Hospital, Unison Medical and Research Center, Mumbai. I take this opportunity to welcome the speakers and panelists, especially Dr. Padma Shri, Dr. Raman Gangahedkar, Professor Dr. O.C. Abraham, Professor Dr. Priscilla Rupali, Professor Dr. Ashit Hegde, Professor Dr. Valsan Varghese, Professor Dr. B.J. Christopher, and Dr. Ishwara Galda, who is the chairman of Unison Medicare. All these panelists need no introduction, and my sincere thanks to the authorities of the ICMR, authorities of the CMC, Vellore, Hinduja Hospital for sharing their experiences. Thank you very much. Over to Dr. Diveshri. Please to start the proceedings of the meeting. Thanks.
Thank you very much for your words, sir. Thank you very much for motivating us to be better versions of ourselves and for leading by example. Now, I would like to introduce you to a very special person. She's an accomplished researcher, an incredible mentor, and a trailblazer in her own right who continues to inspire us every single day. Dr. Priscilla Rupali. She is the professor and deputy director of Hospital Infection Control Committee. She runs many reputed academic programs. PPT. I extend you a very warm welcome, ma'am. I would also like to invite Dr. Jayashree Ghanekar, madam, who is the head of MGM Institute of Medical Sciences General Medicine Department. Thank you so much, madam, for graciously accepting the offer at the last minute when Raman Kedkar sir could not make it at the last minute. Thank you so much, ma'am. Over to you, Priscilla, ma'am, and Dhanekar, madam. Share your screen, Priscilla, ma'am.
Yeah. Can I go ahead and start?
Yes,
Can
ma'am.
everybody hear me?
Yes, ma'am.
Okay, so good evening, everyone, and I bring greetings to you from CMC Vellore. And when Divishri asked me to speak today, I was wondering why CMC Vellore, because I think Mumbai is the place where the maximum cases have been from, and I think we could definitely benefit from your experience. So, so a disclaimer right at the beginning, our case load has been high, but I don't think it's been as high as probably any hospital in Mumbai. A lot of what we have done last year has stood us in good stead for this year. And we are really grateful to God that we are able to live to tell this tale. So this is a presentation based on our experience last year and how we are adapting to this particular year with the experience that we have gained. So this needs no introduction, and all of you know that today we have, India is really suffering under this deluge of COVID-19 cases, and India has taken a particular hit. And you can see that I was trying to compare it with the influenza pandemic of 1918. And we are told that there were 100 million cases and 50 million deaths, etc. And I was looking back to it and wondering what is it that made the change to COVID-19. And as you can see, yes, the cases are probably fast approaching that or have gone beyond that. We don't know whether
आवाज काहीच नाही येते. नाही मला त्याचा आवाज नाही येते ना.
I'm sorry, can you hear me?
Ma'am, we are able to hear you.
Okay.
Yeah.
Okay. Sorry, I just wondered because there was some.
Can I request other people to keep their mics mute? We are able to hear you, ma'am. You can go ahead.
Okay, thank you. Thank you. All right, so this is the global statistics, and Professor Nitin Kalan has also mentioned about how we are reeling from that deluge. So India has now taken the second place in the world. We were behind Brazil for now, till recently. And as you can see here, we are in the second position now. And we've actually had a record-breaking new number of cases per day for over a week now. And this is a bit of a scary specter. And we hope that we are able to learn from each other as to how to better tackle this particular scourge. So like I said, Maharashtra has borne the brunt of it. We are in the 4th place. We don't know whether we will overtake Maharashtra, but our hearts go out to everybody who's dealing with this pandemic, whether it's patients or healthcare workers alike. So I'm just going to this is almost like a story because CMC is a bit like a kingdom. We have 5 campuses. This is our main campus, which has 2,400 beds. We have a new campus, which has about 1,500 beds, which is a trauma center. We've got a secondary hospital in Chittoor, which is the nearby state, and that has about 130 beds. We've got many community outreach centers, one at Rusa, which is a rural unit for health and social affairs. And we've also got a community health and development department, which also caters to certain rural blocks in the community. So what did we do? How did we go through this? So as you know, we started noticing, or rather the world noticed the novel coronavirus in December 2019. And we did see the first case on Jan 27th to Jan 30th is where it was finally reported from India. I do remember I was at a research meeting in the middle of Jan, and I was coming back from Malawi, and I actually saw a number of Chinese workers heading back home, and all of them were wearing masks. And I remember coming back and telling my hospital infection control officer, look, I think this coronavirus might hit us. Why don't we go ahead and make our protocols? And we went ahead and made our first protocol in Jan 23rd, because we didn't really know whether it would really affect us at that point in time. And stupidly, we mapped out the airplane routes between Wuhan and Vellore, and we said, there is no direct flight to Tamil Nadu. We are safe. Nothing is going to happen. But we wanted to be prepared, and we knew that it was coming. By the end of Jan, when Kerala reported it, in February, we actually mapped out the Chinese students who were in our hospital, and we found a lot of them were from Wuhan. And we found that a lot of them were symptomatic and were coming to our emergency department at that point. We didn't really have capabilities to test them. I think it was only available in government centers. That kind of hampered our ability initially. March 23rd is when our first COVID case was reported at CMC, and closely following that, ICMR kindly gave us permission to go ahead and start testing. So I've always wondered, what is it that led to this anxiety among healthcare workers, patients alike, and what is it that led to this chaos? And I think it was a mixture. It was unfamiliarity with this particular disease, the mode of transmission, the medical uncertainty as to how this disease evolves, whom it hit the worst. There were a lot of leadership failures all over the world. You all know the scenario in UK, the US, Sweden. A lot of expert gaffes, in the sense people predicting that it may hit, may not hit. And it was the first time that we were able to think in terms of, okay, it doesn't affect only me, it will affect the community at large as well. There were also a lot of non-medical risks, and it seemed like a situation which was beyond our control. So this is just to lead you through how we did it. Like I mentioned earlier, 23rd January, we did our first protocol. And closely following that, the infection prevention guidelines first came out from WHO. We, at that point in time, were still seeing about 9,000 outpatients a day. And it was immediately, our antenna had gone up, because we were worried that we would start seeing cases, and it would create a center where we would be having, a super spreading event. So immediately we set into motion our triaging system. All our international patients had to go through our triaging system. Symptomatic triaging is what we did initially. And any patient who came in without having had a test at the airport had to undergo at least a symptom triaging, if not testing at that point in time. Anyone from Wuhan or China was immediately referred to the government hospital, because that was what the protocol was initially. At this point in time, we were still floundering a bit, because we were not allowed to test, though we did have the capability to test. So what did we do? As you know, we have a number of students from various parts of the world, UK, US, Europe. At any given time, we actually have 1,000 international visitors or students. We have a separate hostel for them, actually. We also have staff who volunteer with us for various periods of time. So we actually set about creating a system where they were asked to declare whether they were symptomatic. We did a symptom screen in the emergency department and set up what we called as a triage clinic or a fever clinic in February, March itself. Anybody we thought was symptomatic was referred to the government hospital by ambulance if they were sick, but otherwise we asked them to isolate and wait for further instructions to be contacted by the government authorities. Every day, what we did from the Hospital Infection Control Committee, we had a list of high-risk countries, and this was actually updated based on the WHO situation report. We made placards to screen people at gates. We offered masks at the entry gates. I had a register which we maintained with a self-reporting form. And we made preliminary plans in early March regarding IPC, PPE supply chain, manpower, and training as well. Soon, what we did was we knew that there was going to be a PPE shortage. So we went ahead and planned really early. So we ordered a bulk supply of personal protective equipment in January itself, surgical mask, N95, and other gowns itself. And we started restricting access to this because we didn't want the people to use it indiscriminately. We had a flow chart and various protocols that we put in place in the emergency department. We went ahead and divided into two care areas. One was what we call as a SARI zone, that is severe acute respiratory illness zone, and the other one was a non-SARI zone. Thankfully, towards the end of March, we were allowed to test. That was really a turning point for us because we could finally assess what the true risk was. We made a lot of protocols. As you can see here, we had a lot of forms which we asked people to download and fill in. We had varieties of training modules. We had frequently asked questions that we made in different languages that was widely circulated among the community. We made workflow algorithms for outpatients, the casualties, elective admissions, ICUs, and then of course, we also had treatment protocols, which I will talk about the procedure soon. This is an example of a protocol, and she set about making sure that this was being followed at every step. And this was a big undertaking because we have 11,000 employees, we have 9,500 outpatients a day, not to speak of the relatives, and each of them come with at least 2 relatives. So it was a huge undertaking on our part, and I'm really grateful that our medical records department, our security, and the nursing service stepped up to take this responsibility. We had a lot of challenges that we faced, apart from the PPE supply chain not being assured. A lot of the supplies that we ordered were being rerouted. We had widespread anxiety levels among various levels of the staff. We had mutinies among the class 4 employees because they didn't want to work anymore. And then because we had started rationing at that point in time, there was a lot of unhappiness among the various healthcare workers. Challenging times with uncertain treatment regimens, and none of you are unaware of that. Lots of preprint, non-evidence-based treatments. I think the situation is the same today, all available in literature, leading to lots of expert opinions, and consequently led to much angst and confusion. So initially, when we met and we were part of the administrative group as HICC, trying to see what should be our various priorities. And I think one thing we knew that if the pandemic became huge, keeping our healthcare workers was going to be a big problem. So that actually was identified as an administrative priority. And everything was centered around that. So triage and early recognition with isolation and quarantine, contact tracing, even though it's not technically evidence-based, but we did it to protect our healthcare staff. And of course, the various precautions which all of you are aware of. HICC is not really something that is known throughout the hospital, not particularly respected, but suddenly because of this pandemic, we became almost an incident command center with pandemic preparedness and weekly policy updates. We had a triage team, which was formed with members from each group. We had fever clinic, OP screening, IP triaging, crowd control, physical distancing, masking, and of course the various protocols with regard to IPC, disinfection, and engineering controls. The most challenging group was the clinical treatment group, and we realized that there would be no way that one protocol would be enough. We needed to have something where evidence synthesis was taking place constantly with consensus decisions being made. So this was not possible without teamwork, and this really was seamless. It happened to happen seamlessly only because of teamwork. So this is our PPE committee, which was really, I think, everybody in the PPE committee went mad. We started recommending universal masking since March, but we used to have daily meetings, and once a month we had to present to the administration because they had to do modelings to see what our supply chain would be and to predict and to actually make sure that we had enough PPE supplies. Policies changed constantly. As you know, there was a lot of confusion. Was it droplet? Was it airborne? What was it? So we had to constantly look at scientific evidence, contact tracing, exposure. We also had to collect data because people wouldn't believe it because one guideline contradicted the other all the time. We started collecting our own data, and that was the first time HICC started collecting data to be able to make our own guidelines. So it changed constantly. We had a lot of PPE challenges, stock availability, And as you know, we started having a lot of N95 masks being rolled out, which were not great. Though fit tests for all approved masks could not be done because we found a lot of them were failing. So reusing, as you know, was widespread throughout with hydrogen peroxide sterilization. We were a little anxious, so we set out to test it. So this was a 3D model developed by a bioengineering department where we set out to test the filtration efficiency in a crude manner, not the way that the N95 companies do it. There was no way we could ask them to test it for us. So we had to devise our own methodology, and our bioengineering department helped us. This is a hood there, and you can see the particle filtration being read out by that thing over there. Rational use of PPE, we did have protocols, and thankfully those protocols have evolved constantly, and this is a latest version of our protocols where we've gone according to what is the latest evidence available. This was what we had practiced. I wish it was like this all the time, but it is not. And we're not in a lockdown anymore. So it's very, very difficult to maintain physical distancing, encouraging masking, making people wash, making people, follow crowd control and separate entries, etc. But we have tried our best to do this. This is a time when a lot of innovations came into play, and our engineering and our general superintendent's office actually came up with a lot of innovative strategies, mapping movement pathways, coming up with a lot of negative pressure modifications to existing facilities. So we are a 100-year-old hospital, so it's not easy to make modifications, but our engineering department did step up. Triaging areas is our fever clinic. We thankfully had already kind of worked on preparing to deal with a surge in March itself, and it came up practically in a week's time. And we had additional capacity to be able, additional ICU that was with 24 beds, which really helped us during our peak of August, September. We also needed to find a way for patients, relatives to contact their patients. As you know, this is almost a dehumanizing experience. Being admitted as a patient in the hospital with all the strict protocols, with no entry of patient relatives. So we had to design video conferencing facilities and provide people for them to be able to provide tabs and other things for patients to be able to contact their relatives. We added on a financial team, staff, students health service team, and emergency and OP triage teams later on as well, because as you know, the economy suffered quite a bit, and we had increasing number of patients with increasing demand on the hospital, and a lot of the staff had actually to donate their salaries to be able to keep the services going. At this point in time, we also decided to do a healthcare worker survey. We used the WHO model, loosely modeled on what has been done elsewhere in the world as well. And we thought we'd use this to help us inform our training needs. So this was a questionnaire that we administered by WhatsApp after taking their consent. And this is what we actually found. We actually mapped out as to whether they felt that they had received sufficient training to be able to practice the various infection control practices. And based on that, we actually modified our training techniques. So what did we do? We basically had various other policies for contact tracing. Any healthcare worker who was exposed to a COVID patient, either through household contact or a workplace contact, was actually a detailed contact tracing system was put in place. And mainly to give confidence both to the patients as well as our healthcare workers. And these were the main questions that we that we put in place in April itself. And thankfully, that was later on ratified by the WHO guidelines and the CDC guidelines as well. So what did we do? We basically captured positives from the workstation, then we would interview them, ask them for who their contacts were, then we'd trace the patient's pathway through the path in the hospital, and then we'd go ahead and advise for testing or quarantine as required. So this is what we actually did. And when we decided to put the person on quarantine, we also had to contend with the HOUs and the HODs, becoming really angry with us, and staff clinic were to sanction leave for a variety number of people. The other thing that we did was we constantly reviewed our data. And what we found is that this is April to July. What we did was we put in a detailed contact tracing system. Then we realized even with surgical masks, people were actually not becoming positive. So we changed our quarantine advice from August and said, even if you were wearing a surgical mask, you were protected. So how did it actually work out? So this is July to mid-September. You can see how it's actually coming down. And September was actually when we had our peak. This is household exposure and this is the workplace exposure. September was the highest peak we had at any given time, 1,000 patients. But you can see beautifully how the workplace exposure is actually markedly reduced because of incessant nagging, I would say, various training protocols, emails, talking to the HOUs, taking sessions for the people that were there. So what we also found, this is our contact tracing team. You can see how they're sitting in this classroom here. We used this as a measure to revise our policy. It was a passive method to audit our PPE usage and infection control practices and to be able to quarantine staff who were exposed. So these are the various training programs which we had initially, which then evolved into an online system. So this was how we judged whether our training was sufficient or not. So these are all our training modules. We had various phases of training. We are right now in the phase 3 of training, where we evolved from a face-to-face to a complete online mode of training. Now, this is something that we did that was quite, should I say, stressful for us as well. This was a clinical group meeting because there was no treatment protocols available at that point in time. So we had people from infectious disease medicine, pulmonology, medical specialties, and this was chaired by HICC, by an infectious disease physician, and the first meeting we held was on 19th March. So twice a week, we would review evidence. Whatever came up, it would be presented in the forum to get a summary for the treatment protocol. And we'd actually follow up even patients on treatment for clinical improvement. And a further update would be made based on audits as well, till we actually had guidelines from various sources. So this is our latest version of our guideline. We just had a meeting yesterday. And this is how we put it into practice. And this was a very detailed document, not just recommendation, but also the evidence behind it, which we summarize all the trials, we summarize all the guidelines, we summarize all expert opinions at the end of our treatment guideline as well. So this was something that we saw, and this is an article in The Wire, where we mentioned this. And I think what we realized at that point in time is that we need an evidence-based good methodology to be able to come up with evidence-based therapeutic interventions. So we've now begun a project to develop guidelines using GRADE methodology. We hope that these guidelines, which will be available on our website, will be applicable across most low middle income countries. So this is our website. We still are working on it. We have experts from all over the country who are part of these guidelines. We have come up with PICO questions, which are of importance. And we have an evidence synthesis team. And we have methodology backing from the Cochrane ID group. And we have weekly meetings. And we hope to be able to bring out at least 5 modules in the beginning of May. So what did how did it help us? Anticipation and preparation. I thought I'd just put it in. We'd also actually done an oxygen survey sometime in June, July, when we realized our oxygen needs were going to become problematic. Thankfully, at that point in time, we had put in an oxygen generator plant through a foundation, through a grant from the Azim Premji Foundation. And that's the reason why, hopefully, fingers crossed, we are still in a good position today. So innovations, lots of innovations, engineering modifications, indigenous experiments. We did helmet NIV to decrease aerosol generation, procedure boxes which were indigenously manufactured by the emergency department, anesthesia, procedure rooms, gastroscopy, etc., plastic sheeting for high exposure areas, and oxygen supply monitoring. We also did helmets. We tried it out. We conducted various experiments to see whether it would work and whether it was safe. This is an example of an intubation box. I've already mentioned this earlier. Lots of cubicles for suspect patients. And I've already mentioned about the negative pressure that was actually had to be created on the spot with this new methodology of various ducts with negative pressure. So what was our bed status last year? So you can see how it dramatically worsened. From March, we had a single isolation ward, and we went ahead. By September, we had 17 wards in 2 campuses with 75 ICU beds. and we went up to almost 1,000 patients at any given time. As you can imagine, the manpower used was horrific. And to avoid healthcare burnout, we actually had multiple teams with 6-hour shifts. We also had a team which was kind of helping them cope. So people who were kind of boosting their morale. So there was another team looking into it at that point in time. Luckily, this year we're a little better off. We are allowed to isolate patients at home. So though we had put it in place last year, this has come to save us because what we put in September 2020 and it came down. And actually, at the end of February, we just had about 10 or 11 patients on home isolation. Today, we have about 230 patients on home isolation. So we devised a kind of a program, a triage, a risk assessment. Our nurses who kind of, they go to the ED, get triaged, they go to a place where they're taught physically how to use their pulse oximeters, temperature checks, they're taught, and they are, we have made a system for them to call our nurses. Our nurses call them morning and evening and check either through a particular program, through a video call, whether they're able to check their saturation and their temperature. So these are the various protocols that we've put in place. Now, as you know, these surge of cases also meant just to inform patients the results. Like a few days ago, we had 203 positives, 23 positives. To inform just the patients the results, we needed a team. So we realized last year that we needed a team, as COVID command center. There was just modification of the classrooms because thankfully the medical students were not there. So this is what this was the board looked like. Red is the critical bed kind of occupation and the beds that were empty. The next is the level 2, what we call as level 2 people requiring oxygen, whereas basically some indigenous NIV equipment or CPAP or balloon CPAP, etc. And level 1 was that. And these were people in other campuses, which is at the bottom in the dark green and the light green. So what happened here? There was a lot of things going on here: patient information, phone, SMSs, WhatsApp, human resources, repurposing and training. There was a finance department, medical records, patient well-being was being charted, technology, etc. This is what it looked like. I've taken it only when it's empty. Then, of course, we also had to deal with a lot of vaccine hesitancy, and we actually created a FAQ version, and we had to have different versions in Telugu, Tamil, Hindi, English, and we had to go from department to department training people and assuaging their fears. And we have about 90% of our 11,000 employees vaccinated today. So thankfully, this has helped us revise our contact tracing policies as well. And we've been able to bring down a period of quarantine and also the number of exposed employees. So really nothing new from what I'm saying. I'm sure all of you have done this before, but we are so thankful to God that preparation and anticipation was key. Team building and multidisciplinary approach to this helped us. We liaised with various departments to create their own protocols that we were kind of invested in making it work. But the most important thing, I think, for us is, unlike Mumbai, where it hurtled into the pandemic, we actually had time in Vellore and Tamil Nadu to make our protocols. I think that is what really helped us. And so education, training, and retraining. So thank you very much for this opportunity to share with you. And yes, and I hope God is with us as we go through the second surge of the pandemic.
Jayashree ma'am.
Good evening, everyone. Thank you, ma'am. It was an excellent presentation with an excellent planning and a very robust plan to handle that pandemic last year, and the preparedness. That is probably the best part, that you were already prepared probably for the second wave. So thank you, madam, for sharing with us. Only few questions. I am HOD medicine here in MGM Kamote. This is especially for the numbers which we are seeing here. In the second wave, the number has increased right in the beginning as compared to the last year, where the numbers were not much in March, April. We got more numbers somewhere in August, September. But this time, unfortunately, numbers are right in the beginning. Very, very great number of patients. And the other thing is, even the younger population is getting affected. They are becoming critical. Unfortunately, the mortality in younger is more as compared to the last year. So we would like to know what is the status there as compared as in terms of numbers, the severity of the patients and the mortality?
So, ma'am, thank you very much for those questions. I think you all have far more knowledge than we have. But for us, like you rightly said, August, September was our peak. We didn't really have a peak in March and April. So unlike Mumbai, which unfortunately bore the brunt of the pandemic the first time and even the second time, our peak has just about started towards the end of March, the second surge. So till February, from December to February, we had a bit of a lull. Numbers, you are quite right. The numbers have actually hurtled. It's much higher than before. The highest we've ever had is 223 patients positive in our hospital itself 2 days ago. But like you rightly said, the way we've handled it, we were prepared this time. We knew what to do. There was not so much anxiety. It was just a matter of reallocating beds this time. And because our home isolation program, which was put in place in September itself, and luckily had not gone away, we were able to shift the bulk of our patients to this home isolation program, strengthening it, putting in a little more triggers where we were able to handle it better. So actually, right now, we only from the last year's September, where we had almost 1,000 patients admitted for about 3 months or so, right now we only have about 100 patients admitted, all of whom are mostly in the ICU setting. So they're requiring NIV or intensive care. So we have 75 ICU beds right now, which are dedicated to COVID. And we do have a level 2, what we call, but we do even ventilate in level 2 wards as well whenever we run out of beds. So they're all equipped to do it because we put in dialysis lines and oxygen and everything last year itself. So the numbers are more, but we are better prepared, so we're able to reallocate better. That's all I can really say. We are seeing younger patients, you're quite right. The panic among staff is much less because most of them are vaccinated. We didn't lose a single staff, and touch wood and God be praised, last year. And because of the various policies and people started having confidence because none of our people fell sick, 90% of our staff actually came forward to be vaccinated. So we haven't lost a staff yet, touch wood, and I hope God remains with us as we go through this pandemic, because keeping the morale of the healthcare workers was extremely difficult. And I think that has been our main challenge as well.
Thank you, ma'am. Yeah, you are very correct that keeping that morale of especially the young residents who are working for 24 hours in that areas is very important. Dr. Divyashree, I cannot see any other question from any other participants.
Sure. Thank you, Priscilla ma'am, for that exhilarating talk. And thank you, Jayashree ma'am, for moderating. So now we move on. I would like to introduce you to another much admired personality at CMC Vellore, who garners immense respect and love from peers and patients alike, Dr. O.C. Abraham, sir. He's a brilliant mind, an exceptional clinician, and an accomplished researcher. O.C. sir, I think we'll be having a recorded session right now because of the network issues. O.C. sir will probably be joining us at the last few minutes of the lecture to face any questions.
Everybody who is signed in to listen to this conference. Divyashree has asked me to speak on co-infections in COVID-19. So before I begin my presentation, let me thank Divyashree for giving me this opportunity. Like lots, what we have learned about COVID-19 has initially come in the lay press and on messages on social media platforms. The story about COVID-19 associated co-infections is also the same. So this was from lay press about life-threatening fungal infections reported in several COVID-19 patients in India. So this is how the story started. So during my presentation, I will talk about 3 things: COVID-associated invasive aspergillosis, COVID-associated mucormycosis, and co-infections, especially bacterial infections in COVID-19. The story of aspergillosis started as case reports. The story was similar. Most of the reports came from European countries. Patients admitted to ICU with severe ARDS on mechanical ventilation, mostly. Then they had either persistent fever or refractory respiratory failure, and they investigated causes, and they were found to have diagnosed to have pulmonary aspergillosis based either on galactomannan or a positive PCR or a positive culture report. But then, as you know, case reports have their own issues. So then people tried to compile all the case reports and presented them as case series, which kind of tried to shed more light into the problem. But then all these are in the form of short case series which have their own problems. So if you critically appraise the literature, you will find that almost all these are single center retrospective studies which involve very small number of patients. Significant heterogeneity among the published studies. The diagnostic workup and case definitions varied. There was a lack of a control group. Patients admitted to the ICU due to ARDS, due to other community-acquired pneumonias. There was no control group in all these studies. And there was very likely that there were referral and reporting biases. There are two large cohort studies, which I will briefly touch upon, which will shed more light into this issue of COVID-associated pulmonary aspergillosis. This was published in a recent issue of Clinical Infectious Diseases, a study titled A National Strategy to Diagnose Coronavirus Disease 2019 Associated Invasive Fungal Disease in the Intensive Care Unit. This is a national multicentric prospective cohort study done in ICUs in Wales. So they included all the patients admitted into the intensive care units across the whole country of Wales. All these patients were on invasive mechanical ventilation, and all of them had a laboratory confirmed diagnosis of COVID-19. So they had a total of 257 patients, and out of them, 135 underwent a strategy of enhanced screening. What do we mean by the strategy of enhanced screening? Number one, there was an active attempt to get lower respiratory samples, preferably via a bronchoalveolar lavage, and it was submitted to extensive microbiological investigations, which included PCR, galactomannan, and cultures for aspergillosis and other fungal pathogens. They also took blood cultures and did serum beta-D-glucan levels and galactomannan levels. And out of these 135, 27 developed invasive fungal disease, a pretty high number, more than a quarter. And out of this, roughly 14% was aspergillosis and 13% were yeast infections. So aspergillosis and yeast infections were kind of 50-50. This was even more alarming. Mortality was 53% with invasive fungal disease and 31% without invasive fungal disease. So not only does IFD was fairly common in this cohort, it significantly contributed to mortality. And if the clinicians did not start antifungal therapy promptly, the mortality was 90%, alarming figures indeed. Next one was again from a recent issue of Clinical Infectious Diseases, titled Epidemiology of Invasive Pulmonary Aspergillosis Among Intubated Patients with COVID-19, a prospective study. This is from Italy. Again, a similar cohort of patients, prospective multi-center study from several hospitals in Italy. These were all laboratory confirmed COVID-19 on mechanical ventilation. They had a cohort of 108 patients, and out of them, 28% had a probable COVID-associated pulmonary aspergillosis. And patients diagnosed with kappa, the 30-day mortality was 44% when compared to 19% among patients who did not have a diagnosis of kappa. One problem among all these studies have been most of the diagnosis was possible pulmonary aspergillosis and very few probable aspergillosis, and hardly any definitive or confirmed pulmonary aspergillosis. One problem has been the absence of autopsy studies which can confirm the diagnosis of invasive fungal disease. So there is a systematic review of all the autopsies done across the world. This is still a preprint, they're not available in peer-reviewed literature yet. So this was a systematic review of 51 case series of autopsy studies, which included 702 decedents, pretty large number. Most of the patients were from either North America or Western European countries. So out of the 702 decedents, only less than 2%, 1.6% to be exact, or 11 decedents had autopsy confirmed IMD. This is substantially lower than the 25 to 30% reported in case series, even in the prospective cohort studies. Out of this 11, 6 had kappa, 4 had invasive pulmonary mycosis, which was not further specified, and 1 had disseminated mucormycosis. Among the 173 out of the 702 who were on mechanical ventilation, 5 had IMD. So the incidence among mechanically ventilated patients prevalence seemed to be slightly higher when compared to everybody with every patient who died and had an autopsy and was confirmed to have invasive fungal disease. So if you look at autopsy series, it looks like the observation studies are vastly overestimating the problem of invasive fungal disease among patients with COVID-19. So why is that? Probably because the clinical criteria are neither sensitive nor specific. And I said before, vast majority of these patients had possible fungal infections. So you probably are vastly overestimating the incidence and prevalence of invasive fungal disease. So there are many challenges in the diagnosis of invasive pulmonary aspergillosis among patients with COVID-19 who develop severe respiratory failure and need ICU admission and mechanical ventilation. Most of it is the poor awareness. Most of us don't consider a differential diagnosis of invasive fungal diseases when the patient has refractory respiratory failure. We know that the symptoms, persistent fever, difficult to wean off the ventilator, pain, pleuritic type of pain, hemoptysis, none of them are specific. Even the radiological appearance. We know that severe COVID-19 have bilaterally diffuse ground glass opacities and focal consolidation, but it doesn't cavitate. So if it cavitates, you should consider the diagnosis of invasive fungal disease. So symptoms and radiological changes are non-specific, very much unlike the picture you see in febrile neutropenics. It's difficult to obtain deep respiratory samples. Because of issues of infection control, intensivists and physicians who look after these patients in the ICU are reluctant to do a bronchoalveolar lavage. So therefore, you are unable to obtain deep respiratory samples. We know that special lab testing like galactomannan, beta-D-glucan, and PCR are not widely available in our country. And even if it is widely available, it's not available round the clock. They're batched and reported at varied intervals of time. And we know that serum galactomannan has a very poor sensitivity in non-neutropenics, but bronchoalveolar lavage is the preferred specimen in these kinds of patients. And finally, if you culture aspergillus or any mold from bronchoalveolar lavage or tracheal aspirate only respiratory specimen, how do you differentiate infection from colonization? So these are all many challenges associated with diagnosis of COVID-associated pulmonary aspergillosis. To overcome these challenges, ISHAN, International Society for Human and Animal Mycology, has come up with consensus criteria to guide both research and clinical practice. Usually, these consensus criteria are for the purpose of guiding research, but here they said it can also guide clinical practice. Again, I have to make the point that these are only consensus criteria and they remain to be prospectively validated. And how did they classify? It started off with laboratory confirmed COVID-19 with severe ARDS in the ICU, and they are on receiving either IMV or some form of non-invasive ventilation. If there is histology or invasive growth or PCR or galactomannan, histopathology is showing evidence of invasive fungal infection that is proven or definitive, Others are probable when you have microbiology and imaging and clinical factors are present. And if it's only clinical factors are present, it is a possible or putative kappa, COVID-associated pulmonary aspergillosis. This is a very nice recent review from Dr. Contayanis' group in MD Anderson, which compares invasive influenza-associated pulmonary aspergillosis or IAPA with COVID-associated pulmonary aspergillosis, kappa. The IAPA is now a well-defined condition, and it is associated with severe influenza requiring invasive mechanical ventilation. Lots of these patients have underlying immunocompromising conditions, while only about less than 10% of patients with kappa have underlying immunocompromising conditions. The pathology is different. Influenza virus primarily damages the tracheobronchial epithelium, while the problem is diffuse alveolar damage and microthrombosis in patients with SARS-CoV-2 infection. But we know that corticosteroids and other immunomodulatory drugs like tocilizumab have a very important role in the management of severe COVID-19, and they are well known to be immunosuppressive drugs and therefore can predispose to opportunistic fungal infections. So what are the future directions of kappa? So it is still a work in progress. Distinct association with COVID-19 has not been proven yet. It's still work in progress, as I said before. Unlike influenza-associated pulmonary aspergillosis, which is now the association between severe influenza, respiratory failure, and invasive pulmonary aspergillosis is well described. So what are the needs? We need studies with control groups. Other patients with similar etiology, community-acquired pneumonia, but due to other pathogens, admitted to ICU, receiving ventilation. You need a standardized diagnostic approach, and the ISHAM consensus criteria are the right step in the steps in the right direction. And we desperately need autopsy studies. So we like to await for all these things. Like most things in COVID-19, we are still learning. I will move on to the second topic, which is mucormycosis. This is a series from Bangalore in our own country, a very recent paper, SARS-CoV-2, uncontrolled diabetes and corticosteroids, an unholy trinity. This is a retrospective multicentric analysis. They present 18 cases of patients with COVID-19. Almost all of them were diabetics, and they were very sick, and they developed invasive mucormycosis, mostly rhino-orbitocerebral mucormycosis. Again, the problem is that this is only a case series, referral bias, reporting bias. We don't know the denominator. How are these cases sought after? So a lot of unanswered questions. So Dr. Contayanis' group again tried to put together all the published case series, again reported in a recent issue of Journal of Fungi. So they had a review article titled, When Uncontrolled Diabetes Mellitus and Severe COVID-19 Converge, the Perfect Storm for Mucormycosis. After a very detailed literature search, they came up with 41 cases of COVID-19 and mucormycosis. Unlike kappa, most of these patients had proven mucormycosis because it's much more easy to prove the diagnosis, definitely establish the diagnosis of invasive mucormycosis. Very interesting facts. 2/3 of these patients were from India. So India remains the mucormycosis capital of the world. 83% were males. The median age was 55 years. 95% had severe or critical COVID. Severe meaning they had ARDS, critical meaning they had multi-organ dysfunction and needed life-supporting treatment. 88% of them were on concomitant steroids. 94% were diabetics, and the mean HbA1c concentration was 10%. The clinical syndrome was either rhino-orbital mucormycosis. Again, this is work in progress. We need to have more information about this entity. I'm glad to report that the Fungal Infection Study Forum, FISF, and CIDS, Clinical Infectious Disease Society of India, are systematically documenting these cases in our country. Now, moving on to bacterial infections, we have better data This is a study from UK, again a retrospective study. They compared bacterial co-infections in SARS-CoV-2 with influenza patients, two cohorts. So they looked at blood culture positivity and true bacteremia, and they found that the prevalence was similar in SARS-CoV-2 and the influenza group. 9.3% in the SARS-CoV-2 and 6% in the influenza group had positive blood cultures. Out of them, 3.3% in the SARS-CoV-2 and 1.5% in the influenza group were true bacteremias. Most of the source of these bacteremias were non-respiratory sources, like catheter-associated bacteremia or other sources. So the prevalence of true bacteremia is less than 5%, comparable among patients with SARS-CoV-2 and influenza. There's no difference. This is another large cohort study, community-acquired versus hospital-acquired co-infections in Spain. They include a very large number, close to 1,000 patients, 989 to be exact. They had 31 cases of community-acquired co-infection out of this 989, about 3%, and hospital-associated superinfection about 43%, about 4.5%. When compared to patients with no co-infection, either community-acquired or hospital-acquired, patients with superinfections tended to be older, 63 and 67 years when compared to 61 in those with no infection. They seemed significantly had more prevalence of comorbidities like CKD and cancer. And among the laboratory inflammatory markers, C-reactive protein was significantly higher among these patients with co-infections. The co-infection rates was lower than expected from past influenza pandemics, data from Spain itself, and not associated with higher mortality. Very gratifying. Co-infections are lower than influenza. We know that influenza predisposes to secondary bacterial pneumonias, most commonly pneumococcal pneumonia. While that is not the case, at least the experience from Spain from a large cohort, and there was no increase in mortality because of this one. While hospital-acquired superinfection rates was associated with longer hospital stays, more ICU admissions, and higher mortality rates. So hospital-acquired infections are bad news even among patients with COVID-19. This review article from CID, a recent issue of Clinical Infectious Diseases, again compile all the studies reporting bacterial and fungal co-infections among patients admitted to the hospital with COVID-19. Very gratifying to note that only 8% out of this 806 had either a bacterial or fungal co-infections during the hospital admission. So not very high. But despite the low prevalence of bacterial and fungal co-infections, empiric broad-spectrum antimicrobial therapy was prescribed in 72%. So although the actual infection rates are very low, the problem of inappropriate prescription of antibiotics seems to be rampant among this group of patients. So antibiotic stewardship programs have to step up. This study result has led to this WHO guideline, the treatment COVID-19 treatment guidelines, which were updated recently in January. WHO recommends that we recommend for patients with COVID-19 that antibiotics should not be prescribed. So it should not be a routine to prescribe broad-spectrum antibiotic cover for all patients with confirmed COVID-19. If the patient is critically ill, has bilateral pneumonia, severe respiratory failure, on life-supporting treatment in the ICU, it is quite reasonable to start empiric antibacterial therapy and antiviral therapy as per your institution's policy. But once you get definitive culture reports, tracheal aspirate, blood culture, serology, galactoman, and all results are back, please streamline therapy. I think that's my last slide. To conclude, like most things in COVID-19, associated with COVID-19, we are still learning. COVID-associated pulmonary aspergillosis, COVID-associated mucormycosis are major concern. COVID-associated pulmonary aspergillosis because another viral infection which can lead to severe respiratory failure. We know that predisposes to invasive pulmonary aspergillosis, and this is outside the defined host characteristics like severe neutropenia or bone marrow transplantation or iatrogenic immunosuppression, factors which predispose patients to invasive aspergillosis. COVID-associated mucormycosis, again a problem because of this trisection of severe COVID-19, immunosuppressive therapy, and uncontrolled diabetes mellitus. Again, work in progress. Fortunately, you have better data for COVID-associated bacterial infections. They seem to be infrequent, so there's no need to worry about superadded infections, and empiric antibiotics are not recommended as per current recommendations from WHO. I'll stop my presentation here. Thank you for the opportunity, and thank you everyone for patiently listening to my presentation. Thank you very much.
Thank you so much for that wonderful talk, sir. Sir, most of the data that you presented was mainly Western and European. So I just wanted to know, do we have any Indian data or any CMC experience like?
Yeah, the mucormycosis, 2/3 of the cases, even in the review, was from Indian case series. So mucor, most of the data seems to be coming from India. Bacterial infections and pulmonary aspergillosis, I have not seen anything published yet, but I have heard on WhatsApp groups and on the grapevine, if I may. Bacterial infections, personally, I have not seen any pulmonary aspergillosis yet in CMC. We had a few mucormycosis, but I think they were all patients who were treated outside, is what I understand. Bacterial infections, the usual spectrum. They don't come in with coexisting bacterial infections, but we have our own share of nosocomial infections, VAPS and CLABSIs and all the rest of it like that. So are you, do you encourage this practice of empiric antibiotics or antifungals? I just want the audience, to get a good take-home message that empiric antibiotics, antifungals, steroids should not be used, especially in patients who are at home. Like by the time the patient reaches your hospital, patient is already on, they must have received 2 courses of antibiotics. Already they are on DEXA. So you're absolutely right, Divya. I agree with you fully. Most patients we know have mild flu-like illness. They recover with only symptomatic treatment. They do not need antibiotics. They do not need any antivirals. They do not need any corticosteroids or other immunosuppressive therapy. Even patients with moderate disease who are in the hospital, with confirmed COVID-19, you don't need antibiotics. But somebody who has bilateral pneumonia, is on a ventilator, empiric antibiotic therapy is okay, but it should be streamlined, de-escalated once you have bacteriology reports back. So you should not use empiric therapy for vast majority. Thank you. So there's one question. Have you used galactomannan for prognostication? We know literature from at least bone marrow transplant patients that both the level of galactomannan and the drop with therapy, both are prognostic implications, but I have not seen enough data in COVID-associated aspergillosis. I think this was probably related to non-COVID scenario only, sir. Yeah. Thank you, sir. Yeah. Okay. Thank you so much. Despite your hectic schedule, you managed to join us. Thank you very much, sir. Thank you. Thank you, Divya. Thank you, sir. Next, we move on to the next talk. I request Dr. Archana Thakur to introduce Dr. Ashit Hegde to us.
Good evening, everyone. Good evening, sir. It's a great pleasure and honor for me to introduce my teacher and mentor, who is a source of inspiration for all of us, Dr. Ashit Hegde. Sir is head of critical care, PD Hinduja National Hospital, Mumbai. and he's going to talk to us about addressing difficult weaning in COVID-19 patients, which is a real challenge in today's scenario in intensive care units. Thank you so much, sir. A very warm welcome to you, and over to you, sir.
Thank you, Archana. I'll just share my screen.
Sure, sir.
Sorry. Fine. Can you? So I begin with thank you, Archana, for the introduction. So this is slightly change of track. I'm going to talk about difficult weaning in patients with COVID. Before we talk about difficult weaning, we need to talk a bit about traditional weaning. So these have traditionally been the criteria for weaning a patient on a ventilator. I mean, I'm not going to go through them, but these are the traditional weaning criteria, some clinical and some respiratory parameters. And until recently, we have been pretty aggressive about weaning. So if a patient meets the weaning criteria, which have been listed, we would do a spontaneous breathing trial routinely, regardless of the level of ventilatory support, meaning that once he met this weaning criteria, even if it was a pressure support 25 or a pressure control 25 or whatever, provided he met this weaning criteria, we would try once a day a spontaneous breathing trial. And we would accept that some of these patients whom we extubated would end up getting re-intubation. So in most ICUs, probably a re-intubation rate of up to 15 was acceptable. Because if you had no re-intubation at all, it probably meant that many of the patients were being unnecessarily ventilated for far too long and being subjected to the risks of unnecessary ventilation. So barring in neuro ICUs, even 20% re-intubation is acceptable, but in most ICUs, we accepted a re-intubation rate up to 15%. But now in COVID, we know that re-intubation poses a risk, not only to the patient, but also to the person doing the re-intubation. So therefore, we would like to avoid re-intubation as far as possible in patients with COVID. So, I mean, also one reason, of course, is that re-intubation poses a risk, but also to both, like I said, both to the intubator and the person getting intubated, but also patients with COVID don't tolerate, sudden reduction in support that well. They suddenly deteriorate, and then it takes a long time for them to recover, which is why people say that in patients with COVID, you probably need to, be a little more cautious. You need to withdraw support much more gradually because they don't tolerate, this sudden decrease in support as well as patients with other conventional diseases, even patients with conventional ARDS. Therefore, this is what this article by John Marini said, that basically you need to make your transitions cautiously. You need to avoid abrupt changes, and you need to do spontaneous trials only at the very end, which basically means that you probably need to be very conservative before thinking of doing a spontaneous breathing trial. So normally I would do a spontaneous trial with patients with an FiO2 of 50%. Here I would probably wait till it comes down to 35%. I would wait till the supports with the pressure control comes down. So I would be a little more conservative. I would probably delay attempting SBT in patients with COVID because I would want to prevent, I know some patients probably are getting unnecessarily ventilated for a little long, but then I don't want to prolong, I don't want to risk re-intubation in these patients because of the adverse effects of re-intubation. The other thing is that once I've decided this patient is a candidate of spontaneous breathing trial, the decision I need to make is how do I do this spontaneous breathing trial? Now there are two ways. Either you just put them on a T-piece and allow them to breathe unsupported, or you put them on a ventilator, but you give them some amount of pressure support to assist their breathing. And also the duration of T-piece trial varies from 30 minutes to 120 minutes. So if you give a shorter trial with pressure support, obviously it becomes an easier, the patient, the risk of, the chance of a successful weaning trial is higher. And conversely, the more difficult the trial, which means you give a longer trial and you give them a spontaneous trial, the risk of successful extubation it becomes little, successful weaning becomes little lesser. But having said that, the more difficult the trial, the more probable the patient is going to have a successful extubation. And it makes sense that if you give an easy trial, if you give an easy test, some of them might fail later. If you give a difficult test, it's very unlikely that they will fail later. So, so it's a balance between what you really want. So like I said, in patients in COVID, you would want to do a difficult test because you don't want to re-intubate. But the problem with the spontaneous breathing test is that, you don't want to do that in COVID again because of the risk of infection. You don't want, people are scared of, though of course everybody's in hazmat suit, everybody's in a negative pressure room, but still staff are worried about contamination of the environment. So a little wary of doing a spontaneous breathing test in patients with COVID. So at the moment, this study was a little reassuring. The study showed that whether you did pressure support with the 6 millimeters of 6 millimeters, or you did a spontaneous breathing test trial, actually they found that the outcomes are more or less the same, surprisingly, and they found actually mortality was better in patients in whom you did a pressure support trial rather than patients who did a spontaneous breathing test. So what we do now is really do a spontaneous breathing trial on a connected to the ventilator, but we don't get pressure support. What we do is we use a flow by circuit. We do a flow by circuit. Therefore, the moment the patient gets, he makes an effort, he gets air immediately through the flow by circuit. And we do that for about 30 minutes. And then we decide whether the patient is fit for extubation or not. So that's how we do our spontaneous trial in the days of COVID. So it's a balance between not too easy and not too difficult. At the same time, you're protecting the healthcare workers from contamination. Once we decided the patient is fit for extubation, then this is how we do an extubation. This is the days when we were really paranoid about getting infected. Maybe now people are taking intubation, they're not that scared of extubation, but this is what we used to do in the past when we were really, really terrified. We would do a extubation over a face mask. So first we would put a face mask, connect to the filter over the endotracheal tube and remove the endotracheal tube from under the face mask to try and minimize contamination of the environment as far as possible. So that is, of course, if the patient was successful. Now, how would we decide the patient has failed the weaning criteria? You will all know the traditional weaning criteria. I really won't go into that. So these are the criteria. Now, once we also must decide that we are talking today only about weaning failure, because weaning failure is the ability to maintain adequate respiration. We are not talking about extubation failure, which is a different talk altogether, which is their ability to maintain their airway, the ability to clear their secretions. That is a different ballgame altogether. I'm not really talking about that today. I'm really going to talk about only about weaning failure, difficult weaning. So when somebody has weaning failure, what is the pathophysiology? Essentially, it's a mismatch between the load imposed on the respiratory system and the capacity of the respiratory system to take that load. So it's usually a mismatch. And as you see in COVID, each of these causes can contribute, maybe chest wall disease to a lesser extent, but everything else can contribute to weaning failure in patients with COVID. So we first talk about cardiovascular dysfunction. So we talk about difficult weaning of cardiac origin, which is a term been introduced fairly recently. We all know that patients with COVID, COVID can affect the heart and can cause both systolic and more commonly diastolic dysfunction of the heart. And of course, it causes them risk of arrhythmias, but clearly can cause systolic and diastolic dysfunction. Also, many of the patients who have severe COVID have comorbidities. They are either obese and have diastolic heart failure already to begin with. They have diabetes, they have hypertension, they have chronic liver disease, chronic kidney disease. All of them already have at risk of having underlying heart disease. So whatever it is, one of the most common causes for difficult weaning in patients with COVID is probably weaning-induced cardiac dysfunction. How does this occur? As we know, when we are transiting a patient from positive pressure ventilation to spontaneous breathing, the intrathoracic pressure changes from positive to negative. And as a result of this, there is increased venous return to the heart. And as a result of this, there is increased preload. Also, the negative intrathoracic pressure increases the afterload on the left ventricle. And as a result of the discomfort and the increased work of breathing, the sympathetic tone increases. So increased preload, increased afterload, increased sympathetic tone, all of these contribute to weaning-induced cardiac dysfunction in a nutshell, in a very simple way. So how do we diagnose weaning-induced cardiac dysfunction? Now, you must understand that there is no clinical criteria. Any weaning failure could be due to cardiac dysfunction. There is no clue to tell you that this is likely to be weaning dysfunction caused by cardiac origin. Previously, it was thought that if the weaning dysfunction occurs, within the first 5 minutes of a weaning trial, is more likely to be cardiac. Not necessarily so. It can happen anytime in the 30-minute or 60-minute trial that you do. But I agree. If it happens very quickly, the more likely to be cardiac. And also, you must understand that if you add PEEP to your spontaneous breathing trial, then that will mask cardiac dysfunction because the PEEP reduces preload and reduces afterload. So the patient may pass the spontaneous breathing trial, and once you extubate him, then he may get cardiac dysfunction and then may fail, extubation. So it is better when you're suspecting cardiac dysfunction, like I said, not to add PEEP, to do a spontaneous breathing trial without PEEP, just through the flow by circuit. Otherwise, like I said, you might mask cardiac dysfunction. Now, how do you diagnose cardiac dysfunction? Of course, the gold standard is the Swan-Ganz, which you don't do nowadays. But certainly you can do a transthoracic echo after the, if a patient after the weaning trial. And I'm not an expert in echo, but they say E by E more than 0.95 or an E by E prime more than 8.5 suggests weaning-induced diastolic dysfunction, suggests that this might be the contributor to weaning failure. chest ultrasound before and after the weaning trial, showing increase of pulmonary edema, increased B lines, etc., again might suggest that this is because of cardiac dysfunction that the weaning test failed. You can do a pro-BNP before and after the weaning trial. If the BNP has risen by more than 12%, then that could be an indicator that cardiac cause of weaning failure. You should do pro-BNP rather than anti-pro-BNP, because pro-BNP is a shorter half-life, and that's more relevant in this situation. The other thing that you can do is markers of volume contraction. Now, when somebody develops pulmonary edema as a result of weaning, actually the fluid goes from the pulmonary intravascular compartment into the pulmonary, into the alveoli. Therefore, actually there is movement of fluid from the intravascular compartment to the alveoli, therefore actually causing concentration of the hemoglobin and the albumin. So if you look at if the hemoglobin or the protein content has increased by more than 5% before and after weaning, that could be an indicator, a simple indicator that this probably is weaning-induced cardiac dysfunction. And finally, of course, if you have a PICO, you can look at an increase in extravascular lung water, suggesting that this is weaning-induced cardiac dysfunction. Now, what can you do about this? What can you do? Of course, the most important thing is to try and keep them as dry as possible. Obviously, most patients accumulate quite a lot of fluid while in the ICU, so try and keep them as dry as possible. At the same time, of course, we don't want to over-diurese them. So it's been suggested that maybe diuresing and monitoring BNP daily, going by BNP levels, might be a reasonable way of going by deciding that the patient has been adequately diuresed, and so before each weaning trial. So diuresis with monitoring of natriuretic peptides might be a good idea in patients who think have weaning-induced cardiac dysfunction. Other thing, of course, in patients are known to be hypertensive, we need to control the blood pressure before you do the next weaning trial. Of course, remember, in patients who are non-hypertensive sometimes become hypertensive during the weaning trial, but that is more due to pain or anxiety or respiratory distress, not due to hypertension. That hypertension does not need to be treated. But patients who are pre-existing hypertension which is not controlled, you obviously need to control before doing the weaning trial. Drugs like beta blockers and centrally acting drug, the colodine, might be better in this situation because they actually run the sympathetic response. So in this situation, these drugs might be better in the management of hypertension. Patients, nitroglycerin also reduces the preload, also reduces blood pressure. Nitroglycerin can be tried. You start the nitroglycerin trip before you do the next weaning trial, and this might be helpful in patients with cardiac dysfunction, especially if they become hypertensive during the weaning trial. In patients who have diastolic dysfunction, especially patients with LVH or something of that sort, controlling the heart rate with the judicious use of beta blockers and ivabradine might help in the next weaning trial. In patients with systolic dysfunction, drugs like dopamine and dobutamine have not been shown to be very useful because they actually increase sympathetic tone. But levosimendan has been shown to be successful in some patients, so it might be tried carefully in patients with systolic dysfunction and have failed several weaning trials. The other thing that you could do in these patients really is that you extubate them straight to NIV, because you extubate them, you don't give a weaning trial, you just extubate them to NIV because attach PEEP right away, so that it will help reducing the afterload and the preload. That's the other option that you can try, strategies that you can do when you're thinking of weaning-induced cardiac dysfunction. The next thing that can contribute, of course, in patients with COVID is a diminished respiratory drive. We all know that basically at the moment, until before COVID, we were always told that we should minimize sedation in patients with on the mechanical ventilation. We try and reduce sedation, give daily interruption of sedation, try and switch to non-benzodiazepines, try and switch to drugs like methomidine, dexmedetomidine, short-acting drugs, which keep the patient awake. So those were all the things that we were taught about. But we know that in patients with COVID, they don't tolerate interruption of sedation at all. They require lots of sedation, especially younger people, and especially because they're going to turn them prone and so on and so forth. They require humongous amount of sedation. It becomes very, very difficult to taper this off. We really can't. It's not practical to do a interruption of sedation because these patients can crash quickly when you stop sedation. So that as a result of this, and these patients quite often have organ dysfunction, kidney, liver, etc. Therefore, the effect of this sedatives remains even after you stop them. So it becomes very, very difficult. And sometimes these patients, when you stop the narcotics, especially, they develop narcotic withdrawal syndromes, which again contributes. Sometimes when you stop the benzodiazepines or other sedatives, they become delirious. All these things contribute to difficulty in weaning. Unfortunately, there is no easy way of solving this problem. People have suggested that you should try and use non-narcotic strategies, other strategies to try and for analgesia and sedation, which basically means you try and oral drugs. You could try using pregabalin. You could try using for pain control. You could try using melatonin for sleep. You could try using olanzapine for delirium, or for again for some kind of to calm the patient down. So you could try oral strategies in addition to the IV drugs. Other thing is that while the patient is getting better, maybe you could stop your drips. Instead of using infusions of fentanyl, you could try using boluses. So try and wash out whatever fentanyl is there in the system. As you're reaching the infusion, the weaning, as you're reaching weaning, as the patient is getting better, maybe stop all the long-acting drugs. Probably switch to a short-acting drug like dexmedetomidine and propofol alone. And it might be a good idea to continue to try to extubate or to wean on a low dose of sedation, because sometimes when you stop all together, the patients can become delirious, can become anxious. So maybe may not be a bad idea to continue a low dose of sedation while the patient is being weaned, but clearly stop your long-acting drugs if possible. And try and think of other methods. We try and stop fentanyl, and we quite often use ketamine nowadays as a alternative to fentanyl, because fentanyl, in addition to its other problems, also cause a lot of GI problems, which in any case add to the problem that COVID patients have. So unfortunately, there's no great strategy, but some of these things can be done to try and minimize the effect of analgesic sedation in patients with COVID. The third contributor, of course, is impaired neuromuscular function in patients with COVID. We all know our critical illness, polyneuromyopathy. There are lots of reasons for this in other patients, and certainly same mechanisms can function even in patients with COVID. The cannulopathies, pro-inflammatory balance, microvascular disruption, derangements of metabolism, and so on and so forth. The complicated explanations for a problem which most people don't understand. But what can we do in patients with this? Ultimately, there is no great treatment for neuromyopathy of critical illness, even in COVID. We can only try and prevent. So what can we do to prevent this? Basically, you can early recognize and treat infection, because clearly sepsis is a risk factor, critical illness, neuromyopathy. Limit the use of steroids and neuromuscular blocking agents, easier said than done. We know in COVID, these are being used rampantly, quite often because we have no other choice. Try and limit drugs like aminoglycosides, polymyxins also. Tight glucose control, which is the only one that has shown evidence to prevent critical illness neuromyopathy. Early mobilization, this was a challenge because physiotherapy did not come into the COVID ICU, but now we made it a rule that they need to come at least twice a day. So now we are trying to mobilize patients, because this is the only other treatment that can work to prevent and for the treatment of critical illness neuromyopathy. And if the patient is in a breathing mode, try and avoid controlled mode as far as possible if the patient is coordinating, because the more the diaphragm stops working, the more likely the diaphragm is going to have dysfunction, more likely the diaphragm is going to be paralyzed. So as long as the diaphragm is triggering, no matter even slightly with some amount of support, avoid completely as far as possible, try and avoid completely controlled modes, try and as far as possible use, assist control mode so the diaphragm at least is triggering. The longer the diaphragm remains from triggering, the more likely it is to be weak. And the treatment, honestly, like I said, there's nothing much. All these things are just experimental, nothing really great evidence for any of these. You could try, increase protein in their diet. You can try using more vitamins. You can try antioxidants like hormones like growth hormone and testosterone have been tried. IVIG has been tried. Insulin therapy is more related to prevent. And like I said, physiotherapy, early mobilization clearly is the key for the prevention and management of illness polyneuropathy. And finally, of course, the lung disease. We all know that, sometimes patients, it becomes very, very difficult to wean this patient because the COVID itself is not getting better. We know patients are on day 14, day 15, whatever it is, because of either fibrosis or whatever else. The disease itself is so bad that the patient becomes almost unweanable. Now, honestly, there's nothing much you can do in this situation except to look for a reversible factor like a pneumothorax, like a secondary infection. Sometimes you can think of pulmonary embolism, you can image to see any pulmonary embolism. So all that you can do if there's worsening hypoxia or failure of improvement to try and see if anything that you can reverse in the lung. Unfortunately, if you find no reversible factor, then you have to accept that this patient is going to take a long, long time to get off the ventilator, because antifibrotic regimens really take time to work. They will not work dramatically. And if you do start them, they will take 1.5 to 2 months to work. So they're not going to cause miracles. So what then do you do once a patient has failed a weaning trial? You obviously put him back on the ventilator, but you ventilate him on a comfortable mode. So you should avoid over or under support. Basically, the patient should be triggering. Like I said, he should not be completely controlled, but triggering at a rate of about 25 to 30 is reasonable. Shouldn't be too less than that, because too less than that basically means he's being over supported. Obviously, breathing more than 30, it means probably is being under supported. So you try to have a balance between over support and under support. Like I said, you try and see if there's anything that you can reverse, electrolytes, the fluid management, all that we talk, nutrition, etc. Try and reverse any. And you generally, once the patient has failed a spontaneous breathing trial, there is no point in doing a spontaneous breathing trial again that day, unless you found a quickly reversible cause like a pneumothorax or a large pleural effusion. Otherwise, when you put a patient fails a breathing trial, the muscles, respiratory muscles go into fatigue. And it takes some time for them to recover. It takes up to 24 hours for those muscles to recover. So it's better to give it rest for 24 hours and try again the next day. There really is no point in doing one more trial in the evening and somebody has failed the trial in the morning. Sometimes if you think this patient is borderline and you're not very confident, you before jumping to a tracheostomy, you could probably try extubation straight to NIV or HFNO, which means we don't even sometimes do a actual proper weaning trial. We just extubate them straight to NIV and HFNO and then try and gradually come down. That is one other option that you can try in patients who are borderline. In the past, we used to try this only in the really borderline patients, but now in COVID, almost as a rule, I do this, I extubate them to HFNO or NIV and then come down on the support gradually as they tolerate NIV and HFNO. But of course, if all these things don't work, then you have no choice except to sometimes think about a tracheostomy. So that comes to the $1 million question about tracheostomy in patients with COVID. Now, in the past, of course, everybody was terrified of doing a tracheostomy early in patients with COVID because we were worried about, obviously, the patients being, the patients doing the tracheostomy, the surgeons who were doing the tracheostomy getting infected. So people would normally do it only late because it was thought that after 15 to 20 days, people, they would be non-contagious. So people would generally try to delay tracheostomy. They would not do early tracheostomies in these patients. But now the thinking seems to have changed. This study showed that the moment once they did the tracheostomy, clearly the requirement for infusions, for the requirement for sedation came down very, very quickly. So that might be one reason for doing a tracheostomy early, that your sedation requirements might come down fairly quickly. I mean, we have tried in a couple of patients, we haven't been so lucky, but studies seem to show us that maybe if you do a tracheostomy, you might be able to come down on your sedation requirements fairly quickly after the tracheostomy. Then there have been several studies which have looked at early tracheostomy. This is one from Israel, where they write that the accelerated weaning and decannulation in these patients was at least partially due to the policy of early tracheostomy, which means they did it within 7 to 8 days after intubation. And this was a study, a large study from JAMA, which looked at 50 patients. And again, the decision to do early was within 8 days and delayed was after 12 to 13 days, but as a decision of the treating physician. But they found that in the ones in whom the early tracheostomy actually were weaned faster than the ones whom tracheostomy was delayed. Of course, it's possible in some of these patients who were weaned faster and whom early tracheostomy was done, probably did not need a tracheostomy. They might have been extubated, but all said and done, it's impossible to fine tune it to such an extent that it can be perfect all the time. Clearly, if you do an early tracheostomy, some patients may have got away with it, but there's honestly no easy answer. So, but it might be worth considering, especially in patients where the sedation requirements are too high. But maybe, doing an early tracheostomy might be one way in helping you, because it also makes the weaning process much simpler. You just take them off and see how they are. If they're not better, just reconnect them. There's no problem about worrying about extubation, re-intubation, etc. So tracheostomy definitely can make the whole weaning process a little easier. So therefore, finally, we must understand that except if the patient has, in most patients with COVID, except if he has some cardiovascular cause which you have corrected quickly, fluid overload which you have corrected quickly, or some infection which you have corrected quickly, or you have managed to treat his delirium and sedation, etc., fairly well, these patients might get extubated. But most patients probably you have to accept are going to be really difficult to wean. So in these patients, probably the most common reasons for difficult weaning are going to be because of the critical illness neuromyopathy, or because the lung disease itself is so severe. So most of these patients, you will have to accept that they're going to need a tracheostomy. Whether you do it early or you do it later, most of them are going to require a tracheostomy. Most of them will require an integrated approach to take care of everything: nutrition, sleep, psychological, physiological needs, etc. And in these people, you probably need to discontinue mechanical ventilation in a more progressive manner, which means you probably start with very short TPs trials. And as they tolerate, you probably you give them a period of rest, 24 hours, and next day you keep prolonging the TPs trial till they're able to do better on their own. So you have to be patient. There's no other option. In weaning in COVID patients, you really need to be patient, gradually progress the, TPs trials, and that's how you ultimately will succeed. So to summarize, I just talk about a summary. Basically, recognize and correct the cause of weaning failure, mobilize the patient whenever possible, as quickly as possible, actually provide adequate sleep at night, and theoretically to prevent delirium, allow oral feeding, television, newspapers, music, etc. Of course, our country, unfortunately, we don't allow this, but this is probably one of the methods where you can reduce delirium. Obviously, make sure that nutrition is good, especially the protein, correct electrolytes, acid-base metabolic, optimize coronary artery disease and left ventricular dysfunction, reduce the imposed work of breathing, reduce secretions, replace obstructed tube, consider use of bronchodilators and corticosteroids, consider extubation to NIV and HFNC, consider tracheostomy, optimize the ventilator settings, neither over-assist nor under-assist, except a mild hypercapnia. Don't over-assist just because the patient has mild hypercapnia. and improve the patient's respiratory capacity by a respiratory training program. Thank you.
Thank you so much, sir, for the awesome talk. I mean, you touched almost every point in the difficult weaning. There are not much questions actually related to weaning on the chat box. So I think
Fine, that's okay. I agree. This is more of a infection disease.
no, sir, but this is the real challenging thing right now in the ICUs, because especially in the second wave, what we are seeing is most of them they are needing prolonged ventilation, and they are really not coming off the ventilator. Even after doing tracheostomy, they are needing sedation, and the breathing pattern is definitely not settling at all.
Granted, so you just have to go slow. There's no option except patience. The main thing is, I think, infection control, because ultimately, if they don't get secondary infection, they will wean off. But most of them die because they get any.
Absolutely.
I think you just have to be very this about infection control while they're being weaned. They die because ultimately they die of infection. You know, eventually they'll get weaned off if they don't die of infection. So we
Absolutely.
but I think we just have to be obsessive about infection control and be patient. I mean,
yeah, and maybe the the judicious use of steroids, I would say, because people are getting really impatient and they are giving very high doses also.
so I thought you meant judicious meant to use steroid. I agree.
Yeah.
I agree with you that we should probably be a little
Yeah.
cautious about steroid. I think ultimately they're all dying of infection.
Yes.
They're all dying of secondary infection. That is, I think we have to be obsessive about COVID will eventually get better if you're patient, but before that they die of infection. So I think,
Yes. Yeah. Thank you so much, sir. Thanks a lot, sir.
thank you.
Next, we have a very interesting and anticipated talk on pediatric challenges in COVID-19 by Valsan sir. Valsan sir is a professor of pediatric infectious diseases. He's also the additional deputy chair of HICC CMC Vellore. He's a very avid reader, and his areas of interest include HIV, drug-resistant organisms, and vaccine. Our moderator, Dr. Jitendra Gavhane sir, is professor of pediatrics at MGM Medical College, Kamote. He's a very popular pediatrician and one of the driving force behind the Navi Mumbai vaccination drive. Welcome, sir.
Thank you. Thank you to Dr. Divyashree, Dr. Nitin Kadam, Dr. Kalyani Sen, Dr. Jitendra Gavhane, and the organizers at the MGM Institute of Health Sciences and the MGM New Bombay Hospital for inviting me for this talk. So, sorry, I'm just going to share my screen. I thought I had it up there. Doesn't look like it. Can you see my screen?
No, sir.
Okay, just a sec. Sorry about that. Yeah, you can see it now, I guess.
Yes.
Okay.
So we can see it right now.
Yeah. So today's talk is about COVID-19 and challenges in the pediatric population. And the challenges are basically compared to adults with regards to clinical manifestations and severity, diagnosis and management, management of complications, including missed, indirect effects, and the question of vaccines. So, as we all know, SARS-CoV-2 is one of the 3 beta coronaviruses that cause severe infection and the disease is called COVID-19. Now, what has been in the news recently are all the mutations and variants of concern. Just a sec. So when we talk about mutations, the significant ones are those on the receptor binding domain of the spike protein. And these actually give rise to increased transmissibility or affinity of the virus to the ACE2 receptor and the ability to escape neutralizing antibodies or immune escape. The strains that have been in the news recently are the B1.1.7 or the UK variant, which has been found in 80% of Punjab samples. And today's newspaper says 50% of samples from Delhi. And the other one, of course, is the B1.617 in Maharashtra, with 2 new mutations, increased transmissibility and immune escape. 61% of Maharashtra samples, according to most recently released data from the ICMR. So you're obviously dealing with the huge surge of cases there. The question is it more severe? Is it more severe? Is it more in numbers? Is it affecting younger people? So like you heard Dr. O.C. say, a lot of our data is derived from the newspapers and social media. But this data, that is the Hindustan Times and the Indian Express, this is data released by the Maharashtra state government. And when you look to compare 2020 versus Jan to March 2021, what is evident is that at least between this age group, that is 20 to 80, the proportions seem very, very similar. But the difference when you compare it with the original virus and the descriptions from China is that the proportion that makes up 0 to 40 years is just under 50% of all cases. And then when you look more closely at the pediatric numbers, the numbers that affect pediatrics, this is close to 10%, whereas the numbers in China are just over 2%. So numbers, almost definitely you're going to have a lot, or you're already having a lot, and we are also going to have a lot. Severity, we do not really know. The data is not there as to whether this strain is more severe. The only thing we can fall back on is the fact that compared to last year, mortality in children is less, or disease severity appears less in children. And if you look at the case fatality rate, that is 0.2% from China, from the US, as well as from Tamil Nadu, very low case fatality compared to case fatality rate of 15% to 29% in those over 80 years of age. So to understand why disease severity is less in children, let's take a walk through pathogenesis. SARS-CoV-2 binds to the ACE2 receptor, and then a transmembrane serine protease cleaves the spike protein, leading to fusion and endocytosis. This is followed by cytokine release, which is again then followed by endothelial cells moving into the alveoli, and this is in the lung, and pneumocyte proliferation, further followed by increased vascular permeability, leading rise to fluid and edema and a membrane formation within the alveoli, and in addition, microthrombus formation, which gives rise to alveolo-capillary diffusion abnormalities and impaired oxygenation. So why is pediatric SARS-CoV-2 or COVID less severe than adults? Pediatric tissues, especially the lung, has decreased epithelial expression of ACE2 and TMPRSS22 compared to adult lung. And in addition, compared to the pro-inflammatory cytokines that are released in adults, children have more of immunomodulatory cytokines. In addition, children have a more effective cytotoxic CD8 T cell activation and a better humoral antibody response, plus the question about, or rather the concept of trained immunity, that is innate immune memory to frequent viral infections and vaccinations, leading to a better response to new viral infections. So how does this manifest clinically? If you were to look at respiratory symptoms, children, actually only about half of children present with cough, And if you were to take fever and the other respiratory symptoms, then only 73% present with respiratory illness compared to 93% of adults. When you look at the labs, what you find is that a lot of the inflammatory markers, the increased cytokine release that is seen in adults is not commonly seen in children, and it's actually less commonly seen to the range of less than a third. And then this picture on the right of your screen is actually a review where this author tried to predict whether you could have mild disease or severe disease based on the labs. And he said, you know, that there's no way you could predict based on the labs whether the symptoms were going to be mild or severe. If you look at CT findings are similar to those in adults. And you get ground glass opacities over here, consolidation, which is central, in which case it's called a halo sign. When there's a consolidation in the periphery, it's called a reverse halo sign. And within the consolidation, if there are septations, then that's called a crazy pavement sign. It's normally subpleural in the periphery, and conglomeration of all the ground glass opacity progresses to a dense white lung. But unlike in adults, where CT scan findings have a 97% sensitivity, nearly half of children, 1/3 to half of children with mild infection have normal CTs. And as pediatricians, we all know we are not in favor of doing CTs for children. So what we would like to do is actually more of X-rays. Sorry. And so this expert consensus statement came out last year. They said the recommendations are made on the basis of limited pediatric data and literature from adults, which is not ideal. And they classified them into negative, which is no chest findings suggestive of a pneumonia, typical, which is bilaterally present, ground glass opacities or consolidation, indeterminate, where you have peripheral and central GGOs or consolidation or peribronchial thickening. And then the last is atypical, which is not usually found with SARS-CoV-2. And this would include lobar consolidation, around pneumonia, pleural effusion, or lymphadenopathy. They also said imaging is not recommended for children with mild symptoms. And a lot of series have been coming out since this, and a lot of them are reporting that X-rays are normal in 1/3 of children. So X-rays and CT scans are not good predictors of illness in children. I just thought I'll show you a few X-rays, however. You can have perihilar infiltrates, you can have interstitial infiltrates like any viral pneumonia, or you can have findings of ARDS. What has been described in the consensus statement, bilateral lower lobar consolidation or by lower lobar ground glass opacities would also be called typical. This one, you have the star is a peripheral ground glass opacity. You can see a small pneumothorax over here. And you can actually see a central ground glass opacity. If it was bilaterally peripheral, and it would have been called typical here because it's peripheral and central, it's called indeterminate. And this round pneumonia is atypical, and this was due to a bacterial infection. If you were to look at making the diagnosis, now that is not much different compared to adults. The blue line over here is actually the nasopharyngeal swab PCR. The pink one is the bronchoalveolar lavage. They peak between the 3rd to the 5th day and then start coming down. The mean duration is about 15 days for PCR positivity. 50% are negative by 15 days, but they can go down for a week, a month or more. But the virus isolation, although they are PCR positive, is usually not present after day 8 to 10. Stool PCRs, which positivity, which is very common in children, can go up to 6 weeks or beyond 70 days. But here again, almost always no virus has been isolated. So fecal oral transmission is not thought to be a significant driver. Antibodies are formed by the end of the first week, starting at approximately around 8 days. They peak by around 20 days by the middle of the 3rd week. And then IgM starts coming down, and which is the purple dotted line here, that actually sort of goes away by 8 weeks, whereas IgG can persist for around 6 months. So what is evident is that children have a different clinical course. So you have your viral infection and then a recovery compared to adults who tend to have hyperinflammation and older adults who tend to have fibrosis. If you were to differentiate how many or what proportion of your children are likely to have different severity of illness. What's interesting is mild and moderate infection is seen almost equally in children and adults in about 80 to 83%. But children have a higher proportion of asymptomatic infection compared to adults, and adults have a much higher proportion of severe infection, whereas children have it at much lower. And when it comes to critical illness in adults is 10 times that of children. Within age groups, younger infants tend to have the most severe infections of all. So I'm not going to talk a lot about this because I know all of you have your own guidelines, and it's actually available both in the WHO clinical management and the Government of India guidelines. So mild disease 43% is like a URI, no antibiotics or antivirals, nutrition and hydration, and remote monitoring is what you advise. So 43 plus 12, so half your children do not need to be admitted. However, this is what we were doing last year. If you had a pneumonia, which is around 40%, and pneumonia based on the diagnosis based on respiratory rate cutoffs for fast breathing with a normal oxygen saturation, we were admitting these children, doing counts, blood culture, X-ray, monitoring saturation, because we don't know whether they'll worsen or not. And for those under 5 years of age, we were giving empiric antibiotics. In influenza season, we are advised to give oseltamivir, but oseltamivir doesn't actually make any difference. So, that's not followed anymore. With severe pneumonia, which is tachypnea plus one of either cyanosis, respiratory distress, or a danger sign, we ramp up oxygen to target an oxygen saturation of more than 94%. We start broad spectrum antibiotics, and in all these children, we start dexamethasone. And we start dexa, the dose is 0.15 mg per kg, and it's given for 10 days. And for those with a D-dimer more than 500, we actually give prophylactic anticoagulation. So the use of dexa is based on the recovery trial, which showed that dexa reduces deaths by 35% in those ventilated, and by 20% in those needing oxygen. We don't give it to anyone who does not require oxygen. So only for severe and critical illness. For critical illness, which is worsening oxygenation, ARDS, sepsis, and septic shock, our intensivists take over. They would normally start with high flow nasal oxygen with airborne precautions or non-invasive ventilation before moving on to mechanical ventilation. The ones who have gone into ICU with MISC, so they all get fluid resuscitation with crystalloids. A lot of them are still, don't respond or are fluid unresponsive. So a lot of them end up getting vasopressors. Dexa and anticoag is continued if anticoag has been started. Therapeutic dose is only for if there's actual evidence of thromboembolism. At this point, we step up the antibiotics and we start sending in investigations looking for multisystem inflammatory syndrome. So your cardiac markers, your other inflammatory markers, and then we repeat our CRP and D-dimer every 48 hours. So I'm going to talk a bit about the complications. And the first one, of course, is the multisystem inflammatory syndrome in children, or PIMS-TS, then atypical manifestations, long COVID, and indirect effects. So this is a picture of the very first case diagnosed as Kawasaki disease. This is by a young Indian-American hospital pediatrician, had just completed her pediatric training in the US. Jones VG, the VG stands for Veena Goel. She described a 6-month-old with fever for 2 days, rash from day 2, conjunctivitis, strawberry tongue, edema, and erythema from day 4, a typical Kawasaki. Echo was normal, was treated with IVIG and aspirin, was also PCR positive. And this child recovered. And this was followed almost, or rather in the same month, with reports of a 30-fold increase in Kawasaki disease compared to pre-COVID times from Italy and France. And then from June onwards, the US reported that 10% of all pediatric cases were multisystem inflammatory syndrome. So they present as both complete and atypical Kawasaki plus non-Kawasaki symptoms. The differences from classic Kawasaki is they tend to be older, 10 years versus 2 years. Myocarditis and pericarditis is much more common. Platelets and lymphocytes are much lower in this particular manifestation, and a lot of them need a second line of treatment after IVIG. It usually occurs 2 to 5 weeks after infection with SARS-CoV-2. And a lot, because of the late manifestation, they are more commonly antibody positive, but can also be PCR positive in 25 to 40%, depending on when they manifest. The pathogenesis is thought to be, again, a hyperinflammatory response in children with either asymptomatic infection or no pulmonary infection. And people are still arguing about what it is due to, but what is evident is there is T cell activation, marked increase in cytokines, B cell activation and antibodies, and a possible antibody dependent enhancement, and all this giving rise to a hyperimmune response. Now, this is a very interesting temporal graph that shows you when MISC comes in relation to SARS. So the black line is SARS-CoV-2. This is March 2020 to Jan 2021. This is US. So you find that when SARS went up in March, the peak of MISC was around April to May. And when they had their second wave in between June and July, the peak of MISC was in August. And this one is inadequate reporting of MISC, but I think this is something that we need to be aware of, is that the number of cases we are seeing now, we can expect a rise in MISC 2 to 5 weeks from now. So because of that, it's good to know how these children present. A lot of where normally SARS respiratory symptoms are found only in 54%, MISC actually presents 60 to 80% with GI symptoms. And this would include diarrhea, vomiting, and abdominal pain. Among the Kawasaki symptoms, the commonest are conjunctivitis and rash, which are seen in about half of children. Cracking of the lips, desquamation of hands, adenopathy is seen much less commonly. Only about 20 to 40% will fulfill the criteria for a complete Kawasaki. Again, interesting manifestation. Nearly a half can have shock, and renal failure can be present in about 20%. When you look at the labs compared to SARS-CoV, you find hemograms are abnormal, thrombocytopenia is present, acute phase reactants go up, CRP and procal are up in nearly 100%. Liver enzymes are elevated. Other inflammatory markers, D-dimer, ferritin, and fibrinogen increased in 60 to 90%. Cardiac markers up in about 30 to 40%. Myocardial dysfunction in the same number. Pericardial effusions in 24%. Coronary artery changes, which are classically ectasia, dilatation, in about 16%. 10% of these are pleural effusion, and about 5% have ARDS. X-rays can show cardiomegaly because of the poor myocardial contractility or due to congestive cardiac failure. Now, the definition we follow is the WHO case definition, which is fever for more than 3 days, and two of the following: rash or Kawasaki symptoms, hypotension or shock, features of myocardial dysfunction, which can be echo or enzymatic, evidence of coagulopathy or acute GI symptoms, plus elevated inflammatory markers, no other microbial cause of inflammation, and evidence of COVID-19, which is a PCR antibody or a contact. Because there are several definitions, the RCPCH and the CDC have different definitions. So there it is, single organ or multi-organ. I think this WHO definition we've been very comfortable with as far as making a diagnosis. How do we manage? The treatment of choice is IVIG as your first modality of management. And I would, the best document to read is the American College of Rheumatology clinical guidance for multisystem inflammatory syndrome. So they recommend IVIG plus aspirin if there's a Kawasaki phenotype. Therapeutic dose anticoagulation is given only if there's moderate to severe cardiac LV dysfunction. If there's evidence of macrophage activation syndrome, then that's when our rheumatologist prefers to give methylprednisolone, although methylprednisolone is spoken about as an alternative to IVIG. If fever persists for more than 48 hours, consider either a second dose of IVIG or tocilizumab. So I've actually looked at some of the series that have been documented last year, and this is US data from a registry. This is Chennai, 19 children. This is Mumbai, and I'm reading this out from a newspaper from a piece of paper because I'm not all that familiar with all your hospitals. And this is from BJ Wadia, SRCC Children's Jupiter Hospital, and Kokilaben Dhirubhai Ambani. So 23 children. What is interesting and striking here is if you look at management, almost always it has been IVIG and steroids. This little series here is from our ICU. This is all the children who are admitted with MISC. Interestingly enough, the use of tocilizumab is very, very little, even in the US. In Chennai, it was 1 child out of 19. In Mumbai, it was 3 children out of 23. And in our ICU, we never used tocilizumab. Outcomes have been relatively good throughout. So what is the long-term follow-up you get? Outcomes are almost always good. Time from treatment to remission of fever is 2 to 5 days. Inflammatory and cardiac markers will resolve within 2 weeks. LV function recovery, 90% in 30 days, nearly 100% by 90 days. And coronary aneurysms regress to normal in 80% by 30 days and 100% by 90 days. So I'll just talk now about a few of the atypical manifestations, and because of the numbers, we are likely to see these. Almost all of these are case reports. They are seen basically because ACE2 receptors are omnipresent in almost every system. Conjunctivitis without MISC, gross hematuria, new onset nephrotic syndrome that was treated with steroids, rhabdomyolysis treated with fluids and recovered, oculoepididymitis, and a lot of GI manifestations, including neck, protein-losing enteropathy, intersusception, mesenteric adenopathy, pancreatitis, jaundice, and fulminant hepatic failure. So all these are almost always case reports with SARS PCR positivity. So they are not actually manifestations of MISC, but can be seen during the initial phase of the infection. Now, this is an interesting article which has just come out in JAMA Neurology in March this year. And this is a series of neurological manifestations. And this is from a US COVID registry of 1,695 children. Only about a third met criteria for MISC. 22% had neurological involvement. I just want to walk you through the symptoms because, and this is divided by age group. The light bar here is less than 5, the gray one 5 to 12, and the dark one is 13 to 20 years. Seizures, commonest manifestation, most commonly seen in under 5s. Loss of smell, loss of taste, most commonly seen in your older adolescents. Headache seen in children aged 5 to 20 years. And altered sensorium can be seen across the board. So of the 365 who had these neurological symptoms, in 88% the symptoms were transient. Only 12% had life-threatening conditions, which included encephalopathy, stroke, demyelination, Guillain-Barré syndrome, and acute cerebral edema. In all 4 of these, there's a secondary to seizures. 11 of the 43 died. 17 of 32 survivors had neurological deficits. At discharge, this particular article did not talk about follow-up. This needs to be mentioned because this is also temporarily related to SARS-CoV-2 infection. This is called chilblains or COVID toes. These are erythematous papules or plaques on the toes of adolescents or young adults. They occur 1 week to 2 months after respiratory symptoms. Almost always PCR and IgG negative, but a lot of them have been IgA positive. Skin biopsies have shown viral particles on electron microscopy, and immunohistochemistry has been positive for spike protein in the endothelial cells of the dermal capillaries. It's thought to be due to an immune-mediated vasculitis and resolves without treatment. Other manifestations that have been seen are purpura, maculopapular lesions, eczema, urticaria, erythema multiforme, all of which can be seen with several viral infections. Now, long COVID, and long COVID is more described in children, adults, nearly up to a third. It's basically symptoms that are persistent for 2 months or more. Over the past 1 year, there have been only 2 small case series in children and 1 follow-up study from Italy. They're usually age 9 to 15 years. Longest duration in a child was symptomatic at 6 to 8 months after the diagnosis. The commonest symptom was fatigue, followed by myalgia and arthralgia, headache, palpitations, abdominal pain, difficulty in concentration, poor appetite. Symptoms have been described by the parents as disabling. Now, because they tend to cluster in family members, the question is it a predisposing genetic or just an environmental trait or stress due to the pandemic and the lockdown? Which actually brings me to indirect effects due to the lockdown. And one of the things that affects us as a country would be food insecurity and malnutrition due to absence of school meals. And this is thought to affect 200 million children globally. And because as pediatricians, we deal with all socioeconomic strata, we know that in our higher income households, that decreased physical activity is going to lead to obesity. Now, this very interesting graphic over here is basically screen time. And this is daily screen time. And you can see that before lockdown, it was around 3 hours. And after lockdown, and when there's no school, it has gone up to 7 hours. This is from Germany. And why are we worried about increased screen time? It's basically because in the first 2 decades of life, there are studies that show that increased screen time is associated with myopia. Add issues of mental health to this, including loneliness, anxiety, addiction, antisocial behavior in adolescents, domestic violence, and the threat of sexual abuse. And in addition, the effect of educational loss on future socioeconomic status. And this author actually said, the answer is clear. Let's just open the schools. But when you open the schools, this is actually what you see. This is from Berlin in Germany. This is during the lockdown, no outbreaks. Before the lockdown, 3 outbreaks per week, 6 cases per outbreak. After reopening schools, 2 outbreaks per week, 4 cases per outbreak. You can actually say these are small numbers, they are children, they are mild, they are not going to have trouble. But if you look at these yellow bars, those are actually the over 21. And the over 21 are actually your teachers, your support staff, your drivers, so you are actually putting a lot of adults at risk. So what can we do? You need to reopen schools. The CDC has actually come out with criteria on how to safely reopen schools, which talks about using masks, social distancing, staggering school class timing, staggering arrival and departure from school. But when you look at it, you realize only about 50% of that is applicable to even our private schools. So I was looking at that page and I came across this little picture at the top of the CDC page, which said, get a vaccine. So let's take a look about what is the current status of vaccination. Pfizer has completed trials in 12 to 15-year-olds. Moderna is completing in 12 to 17, and they are going to be asking the US FDA for permission to vaccinate these children. They have started trials in 6 months to 11 years of age. AstraZeneca has started trials in 6 to 17 years old in February 2021. And on 16th of April this year, UK has advised vaccination of pregnant women with Pfizer and Moderna vaccines based on safety data from the US. Now, as a pediatrician, why am I interested in immunizing pregnant women? And this is the answer. That is, these are 2 small studies which came out in the American Journal of Obstetrics and Gynecology in March this year. Third trimester women who received Pfizer and Moderna vaccines had 26 of 27 had positive SARS-CoV IgG, and then they looked to see how many of their infants had. And except for 3 infants who did not, in whom or whose mothers did not have the second dose of Pfizer or Moderna, every other infant had positive neutralizing IgG antibodies. And what is interesting is the earlier you took it away from the pregnancy, the higher the risk, the higher the ratio of transmission of antibodies to the infant. And then this other article on 5 breastfeeding mothers who received 2 doses of Pfizer vaccine, positive IgG antibodies starting at 20 days after vaccination, and that's because they measured it just before the second dose of Pfizer, which is 21 days. The antibodies lasted up to 80 days. And passive transfer of antibody is something, it's not a new concept. It's been done for influenza, it's been done for pertussis. So this is actually something positive which we can look forward to as and when the government decides to vaccinate pregnant mothers. We'll probably be protecting the tiniest and the highest at risk among our pediatrics. This article was followed in April this year by another study on 84 breastfeeding women from Israel, and 97% had neutralizing IgG antibodies 6 weeks post-vaccination. So that brings me to the end of this presentation. Just a few takeaways. 1, COVID infection in children is less severe than in adults. I know you are dealing with terrible numbers there, but severity is less based on what data we know so far. multi-system inflammatory syndrome in children is treatable with medications available in India. Vaccinating pregnant women may offer us options for protecting infants at risk. So it's true that there is so much that we do not yet know, but according to me, the future is not entirely bleak. Thank you and stay safe.
Thank you, sir.
Yeah.
Thank you for a wonderful overview of pediatric COVID cases, right from basic pathophysiology to vaccination. You covered everything, including the MISCs and long COVID phenomena. Sir, I want to know, like in chat box, there are a few questions. I'll take them first.
Sure.
Sir, one question was whether the child is mostly asymptomatic and mildly symptomatic, still he will get MISC. I think you covered in your talk about that, but still for the audience, you can tell again.
Yes, so that is the one thing to watch out for, that with mild symptoms, the child can still have multisystem inflammatory syndrome, and that normally occurs 2 to 5 weeks later. So I think, especially when we counsel parents, we need to tell them, look, it's mild infection, but you need to keep in touch with us in case there are any long-term complications. And people are so scared of COVID that if it's your patient coming in touch with you, they will keep in touch with you. And the thing is to let them know early what the signs, and that would be fever, rash, or anything that has occurred 2 to 5 weeks after your first infection.
Yes, sir. Sir, currently we are seeing, as we are at the peak right now than your state, currently we are seeing cases who are not fulfilling the proper WHO criteria for MISC or MAS together, but they are having rebound like second biphasic fever coming with some rash as early as 10 to 12 days also, and few inflammatory markers are coming high. So is it a spectrum disease, sir?
Yes, it is actually. So that you would, especially if you've not been able to discharge them, there's no doubt that you can actually have you can have a spectrum. And if you're saying 10 to 12 days, that is just around 2 weeks. None of this is a hard and fast 2 weeks. It can, especially if you have increased inflammatory markers and a rash, I would say this is a suspect multisystem inflammatory syndrome. And if you look at the definitions, there are so many definitions that almost always, this will fit in with a single organ definition, which is what I think the CDC follows.
Yes, sir. Sir, at our center last year in first wave, we saw almost 15 to 16 MISC who fulfilled WHO criteria cases, and none of them we gave TOSI, and I think adult people are also now discarding TOSI from WHO tray. Also TOSI is going out because, as Hegde sir said, infection is the most difficult thing after TOSI to control, and that is the main cause of mortality. So in children, we have really not used, sir. Sir, a few of the centers where like only pediatric COVID ICUs are available, and young adults coming with bilateral pneumonias and requiring support ventilation, sir, there they are thinking of starting remdesivir. So what is your experience about that, sir?
So we've never used an antiviral. We've never used it in children, not because it wasn't available, but I think in pediatrics, there was very little evidence in adults to start with. A lot of the series from the US, Europe have all used remdesivir as emergency use authorization. But there also, there have not been any standard trials. And I think the American Academy of Pediatrics also quite early on last year said they see no evidence to start an antiviral. So, I think that is a good takeaway for us, that we shouldn't be using things. And we're talking about tocilizumab. Tocilizumab is extremely expensive and has a raft of side effects. We are giving dexamethasone here and hoping they don't get an infection. Like Dr. Hegde said, luckily we've not had a secondary bacterial infection, but why do you want to, immunosuppress this child further?
Absolutely, sir. Yes, sir. So again, TOSI, like TOSI, REM also is out of WHO box, I think, for adults as well. So we should not send relatives to hunt for remdesivir vials and ignore the child's present condition and give supportive management. Right, sir?
Absolutely. I think this supportive we cannot emphasize enough that supportive management is the mainstay in children. And steroids if they are
Yes, sir.
sick.
Hypoxic. Yeah.
Yeah, sure.
Sir, I think we pediatrician were unfortunate that trials were not included pediatric age group first time itself, so that we could have also given vaccine right from the first phase itself to our children, and that would have definitely made a difference for the MISCs and all. Anyway, now trials have started. Even Covaxin has started their trial. So let's hope that we get authorization to start immunization in pediatric as well.
I agree with you.
Yes, sir.
I agree with you, but the issue is, if you look at the normal way trials progress, children and pregnant women are almost always after your initial phase 3. So,
yes,
it's
sir.
just
Yes,
that
sir.
the virus has been faster than us, so to speak.
Yeah, and there was no much knowledge about virus last year, and this year we are more wiser in all aspects, right, from preventive to and sir, one more take home message is our children, we advise masking and all, and they're really religiously following than adults. What is your experience, sir?
No, absolutely, they'd actually follow. I think the CDC says for children above 5, as what a lot of the other people are saying, children about 2. So I've seen infants walk into my OPD with one, covering.
Yes, sir.
So
and that has reduced the other respiratory viruses so much, sir. Yes.
Absolutely. In fact, influenza is down, bronchiolitis is less.
Absolutely, sir. Yes, sir. Thank you, sir. Thank you for
very much.
all the knowledge you shared with us, sir. Thank you. Over to Devashri.
So thank you so much for that enlightening talk, and Gavane sir very, very nicely moderated. We now move on to our next talk, which is early identification and prevention of pulmonary sequelae in COVID-19 patients. The talk will be given by DJ Christopher sir. I don't think I have words or means to describe DJ sir's achievements. He's a one-man army. He's currently the professor and head of pulmonary medicine department. He's also the associate director of CMC Vellore. He is single-handedly, he has brought too many changes in the Department of Pulmonary Medicine. He's received several national and international awards. He has multiple publications, and he's also a member of the WHO COVID-19 Respiratory Support Group. This session will be moderated by our Deputy MS and intensivist, Dr. Tushar Sontakke.
Can I start, Devashri?
Yes, sir.
Okay. Good evening, and I'm very, very pleased to be in your midst. I want to thank the MGM Hospital Group for kindly inviting me to this very informative session from which I myself have benefited so far. And also thank you for those very kind words of introduction. I was Associate Director, not anymore. So getting to the topic, my topic is early identification and prevention of pulmonary sequelae in COVID-19 patients. I'm going to talk about an area that we are going to be left with after the COVID pandemic passes. At the moment, we cannot look beyond the pandemic. But when we get there, we are likely to be faced with the problem that I'm going to talk about. So this is from a lecture I took in December. So I said that there will be several waves, and some of them can be large waves, and we should prepare for the pandemic 18 to 20 months down the track. So at that time and subsequently, things started looking very good, that we hoped that we would have seen the last of the virus. But we were all sadly disappointed and mistaken. And we are indeed now inundated with wave that is much bigger than the first wave. Now, from the birth, as the child is born, it takes its first breath. And then finally, the person breathes their last. And that is the end of life. And between the beginning of life, from the first breath to the end of life, when the last breath is taken, we need the lungs healthy to ensure that we have the oxygen that we require to sustain life. The lung is a phenomenal organ. There are 10,000 liters of air that pass in and out of the lung every 24 hours. Likewise, there are 10,000 liters of blood that pass the lungs every 24 hours. Overall, 420 liters of oxygen are consumed per day and 350 liters of carbon dioxide exhaled every day. Now, this crucial organ is required for everything in life. Now, looking at the primary symptoms of COVID-19, we are aware that symptoms may appear 2 to 14 days after exposure to the virus. And there are myriad symptoms, but I just want you to understand that shortness of breath is a crucial symptom, and that in many ways determines the quantum of care given. And that is a symptom that every patient and every physician will dread. This is early data from China that outline the key findings in patients, all patients, non-severe patients, and severe patients. This was published in NEJM somewhere in the middle of 2020. What is crucial is that abnormalities of chest X-ray were seen in 59% of patients, and in the severe group, it went up to 76%. So this is as far as plain chest radiograph is concerned. But when you took a CT scan, all patients 86%, severe 94.6%. So what is amply clear is a vast majority of our patients, even if they do not have severe disease, have lung involvement. Now, how does the lung heal? The lung heals with fibrosis. The inciting agent could be an infection, as in the case of COVID-19, or as in the case of tuberculosis or pneumonia. It could be insult from drugs that cause alveolitis and then fibrosis, or anything. But this is the way the lung heals. And so we would expect some sequelae as the lung heals. This is the case of a 48-year-old male who presented to us with shortness of breath, MMRC grade 3 on 8th of December 2020. He had been diagnosed with severe COVID-19 in September 2020. Non-smoker, no past history of TB or serious lung infections. He had a complicating nosocomial pneumonia with Klebsiella during the episode of COVID. He was newly diagnosed diabetic, diagnosed when he was also diagnosed to have COVID, and his symptoms improved and he was discharged on home oxygen. This was his CT at the time of diagnosis of COVID. You can see that the entire right lung is consolidated and there are some ground glass shadows, but mostly dense consolidation. And this was the X-ray, this was the CT image that we saw. For the sake of comparison, I'll put the old images also. Where there was this consolidation, there is more ground glass shadows remaining. There are some cavitary lesions, some bronchiectasis, and this is how the lung looks post-healing. This is the coronal section showing the same thing, but to see that this was the initial image and this is the image at present. So the final diagnosis was post-COVID pulmonary fibrosis, recurrent nosocomial, recent nosocomial pneumonia, and diabetes. So I want to go back to the lung fibrosis is this a new phenomenon? Has this been seen with the previous coronavirus infections, namely SARS-1 and MERS? So this is with SARS-1. 383 clinically diagnosed SARS patients in Beijing, China, of whom 27.3 had lung diffusion abnormalities and lung function testing, and 21.5% exhibited fibrosis on CT scan. They were followed up at 2 months. This is the lung function in these patients. At 2 months, about 87% had a reduction in vital capacity with one of the measurements, which improved at the 4th month point to 94%, then 100%, and 11 months, 102. So by 11 months, gradually it had reached normal. FEV1, which is another parameter that indicates obstructive lung disease, improved from 83% also to 96%. So pretty much reached normal in 11 months. Diffusing capacity, which is a more sensitive indicator of impairment of fine fibrosis, it was 69% to start with, and even by 11 months, it had not completely reached the normal range. So this is with SARS-1. And these very same patients were followed up several years later, 15 years after the 2003 SARS-1 infection, looking at lung and bone outcomes. Why bone outcomes? Because a lot of people were treated with steroids, and so they had steroid-related damage to their bones, in particular to the femoral heads. So this study looked at, evaluated them with CT scans of the lungs, with lung function tests, hip joint MRI, and functional questionnaires. So the percentage area of lung lesions diminished from 9.4 to 3.2 in the first year itself, and then stabilized till 2018. So they gave a more positive outlook that, oh, maybe 1 year it gradually improves, but it then remains at the level where it improved. And with regard to the femoral head osteonecrosis, improved from 30.8% to 30.4% in the first 2 years. And then slowly it improved till 2030, after which it plateaued. There was no further worsening, no further change. So this is the summary of the findings 15 years later. So it appears from the lung point of view, let's for the moment leave out the orthopedic matter, that improvement happens over 1 year, but then it stabilizes. So this is the same thing, the lung function as you see. So you can see that things are down, but it picks up, reaches plateau, and continues to remain stable. This is a study that looked at the MERS group. So we looked at SARS-1, let's look at the MERS. After recovery, 36 patients with a mean follow-up of 43 days were evaluated. 33% had lung fibrosis, 5.5% had ground glass opacities, and 5.5% pleural thickening. So at 43 days, about 1.5 months, fibrosis was seen in about 33%. This is in May 2020, fairly early in the pandemic. This insightful article appeared in Lancet, Pulmonary Fibrosis Secondary to COVID-19, a call to arms. So this study said that long-term pulmonary consequences remain speculative. At that point, it was only speculative. We have not yet begun to see long-term complications. I think we have already seen that this is a reality now. And they said at that time that given the large number of patients affected with COVID, even a rare complication will have major health effects at the population level. It is important to be prepared for this situation. It was an excellent clarion call for the future. Now let's look at post-COVID fibrosis with SARS-CoV-2. This is data from China in March 2020, 46 patients, retrospective study. of CT prior to diagnosis and follow CTs up to 1 month. So this is their conclusion. Typical early changes for ground glass opacity is predominantly located in the peripheries or subpleural locations and pulmonary arterial dilatation. Reticulation is evident after the second week and persists in half the patients evaluated even after 4 weeks. Long-term follow-up is required. So what is clear is that 4 weeks imaging findings still remain. So this is a study by Liu et al. Looking at pulmonary sequelae in patients discharged. Again, a short-term observation study. They imaged 146 patients prospectively, had CT imaging done at 1, 2, and 3 weeks post-discharge. And this is what they demonstrated. They showed ground glass shadows, then fibrosis, bronchoalveolar bundle changes here, pleural effusion here. So all these changes were plotted. And as you can see from the first CT going through to the third CT, there is improvement of all these findings. Now, what is lingering at third, fourth week is ground glass shadows. And they have still not resolved, they continue. So we know, as in the previous study, that early in the recovery phase, 1 month, 6 weeks, CT abnormalities still remain. So the study concluded that 2 weeks after discharge may be an optimal time for evaluation of lung damage. Most patients have substantial radiologic recovery. Ground glass opacities take longest to recover. Elderly seem to take longer to recover than younger people. This is a study by Pan et al. They looked at the time course of lung changes at CT during recovery from coronavirus, like COVID-19, of 21 patients. And these people did a very aggressive once in 4-day CT. So you can see here in the plot that each dot is a CT scan. And they followed up their 21 patients. And this is the plateau. You can see that by 21 days, things have recovered, but still not come to normal. Same you see here at 25-day point, things have not completely become normal. And the summary of this study was that in patients recovering from coronavirus 19, 4 stages of evolution were noted on CT scans, which were early phase between 0 to 4 days, progressive phase between 5 to 8 days, peak between 9 to 13 days, and absorption stage after 14 days. Now let's look at lung function studies. Before that, let me give you a little basic overview of assessment of lung function. There are probably 3 major lung function abnormalities that we are concerned about. One is obstruction. So this is a normal airway. And when there is damage to the airway, the airways can become narrow. This typically happens in COPD and asthma. Such an abnormality can also happen with infections like COVID-19. And so this is measured by what is called FEV1 forced respiratory volume 1, which reduces. The other abnormality is a restrictive defect wherein the total lung capacity drops. This is a normal lung. This is a restrictive defect lung where you can see the lung is now smaller. And this is measured by total lung capacity, which or forced vital capacity. Both these parameters tell us if they are reduced that there is a restrictive defect. And the third is a diffusing defect. And this is the alveolus where the air comes in. And this is the capillary. You can see the nice contiguity in these 2 structures so that there is seamless transport of gases from the alveolus into the blood vessel and reverse from the blood vessel into the alveolus. Now, if there is fibrosis or any damage to this apparatus, then the gas diffusion is important. And this test is extremely sensitive for fibrosis. So probably the mildest change will show in the impairment of diffusing capacity. So when we look at various study findings, you may be able to relate to what I'm saying. So this is a study that looked at lung function in the early convalescence phase. In 56 patients, 57 patients, 17 had severe disease, 40 had non-severe disease. 30 days after discharge, lung function test, which is the standard full lung function test, respiratory drive for muscle strength, respiratory muscle strength, and 6-minute walk test for exercise capacity, and CT scan were done. So these were the findings. The total lung capacity reduced significantly, and that indicates that the lung volume has become small. And R20 is reactance, and more importantly is the walk distance. The 6-minute walk distance, which indicates exercise capacity, has dropped. And diffusing capacity. I told you that this measures the diffusion between the alveolus and the capillary, and it's a very sensitive test. And that also was significantly lower in this group. So they concluded that impaired diffusing capacity, respiratory muscle strength, and lung imaging were detected in more than half of the COVID-19 patients in early convalescence phase. Compared with non-severe, severe had higher incidence that we would expect. This is a late-breaking abstract in the European Respiratory Society meeting 2020. They looked at pulmonary impairment following severe SARS-CoV-2 infection. This was from Austria. They took patients discharged especially from ICUs, and they followed them up weekly. The first visit was the 6th week, and the second visit the 12th week. And dyspnea was present in 40% of the patients in the 6th week, and present in about 30-odd% in the 12th week, which is the three months. So after 3 months, nearly 30% of the people had dyspnea. Forced vital capacity, which is the total measure of total lung volume, was low in about 25% in the 6th week, and it was low in about 18% in the 12th week as well. And diffusing capacity again was low in 40%, but again even in 3rd month point, 20% had impaired diffusing capacity. And CT scan findings were there in 80% in 6 weeks, and were still present in over 40% at the 3rd month or 12-week point. This is follow-up lung functions in 3 months after recovery of 55 patients with non-critical illness. These were not from ICU, these were patients without critical illness. And even in them, 71% had radiologic abnormality at the 3-month point. 7.2% had ground glass shadows, and 27.2% interstitial thickening, and 5.4% had what's called crazy pairing. Lung function abnormality were detected in 14 patients, which is 25%. So at 3-month point, 25% had abnormal lung function tests. And also the study showed that higher levels of D-dimer admission was associated with reduced lung function as measured by lower diffusing capacity. So overall, looking at various studies, the risk factors for lung fibrosis after SARS-CoV-2 are elderly people of more than 65, illness severity, length of ICU stay and mechanical ventilation, smoking, and chronic alcoholism. We will now go on to look at follow-up and management approaches. What can we do? At the outset, let me tell you the best management approach, the best way to prevent. I was a little intrigued by the topic. How do we prevent? I think the best way to prevent is to prevent COVID-19 infection. There's no better way to prevent lung damage than that. So this is the British Thoracic Society guidance on respiratory follow-up of patients with clinical radiologic diagnosis of COVID-19. It was published in May 2020. They said that patients who were cared for in ICU, or in the ward with severe pneumonia need subsequent follow-up. I hope we are doing this. At the 4th to 6th week point, they are being cautious. They didn't ask them to come to the hospital. They had a telephonic consult, asking them about new diagnosis of pulmonary embolism. They also discussed with the team that looked after them. And then they had a post-COVID-19 holistic assessment of symptoms and other things. And at 12-week point, they made it mandatory for them to come face-to-face and did full lung function test. And if PE was diagnosed, there was a PE follow-up, then 6-minute walk test and oxygen saturation were measured, and COVID-19 holistic assessment was done, sputum sample echocardiogram. And if they were all normal, they were discharged. So patients need to be assessed, especially if they had COVID-19 pneumonia, had any form of severe illness. Even if they didn't go to ICU, they should be evaluated. And if everything is okay, you can clear them. If there's evidence of pulmonary vascular disease, abnormal chest X-ray or lung impairment, they should have a CT scan, CT pulmonary angiogram, echocardiogram. If there's evidence of pulmonary vascular disease, they go for pulmonary hypertension service. If they have evidence of interstitial lung disease, they go to the ILD service. If there's no evidence of ILD or pulmonary vascular disease, then alternate management is carried out. So this is another late-breaking abstract, the European Respiratory Society meeting. I said that this happened in November, looking at the weekly recovery of physical capacity in patients with COVID-19 post-extubation pulmonary rehabilitation. So these patients were started on pulmonary rehabilitation early after their illness. And this is their weekly assessments. They looked at 6-minute walk, which is an excellent measure of their exercise capacity. So what they showed is that every week, this is what each patient, and every week you see that the 6-minute walk capacity has improved in every patient. So they concluded that rehabilitation is an important aid and is likely to facilitate recovery of patients. Now I want to digress a bit and talk about what is the big deal, what lung function reduces in patients. In the Framingham Heart Study, which many of us know as a landmark cardiovascular study, researchers followed 5,209 participants over 18 years. One of their biggest findings was that the risk of congestive heart failure rose as the lung capacity fell. Very unexpected finding. The lung capacity was measured with post-vital capacity. The relationship was independent of blood pressure, relative weight, pulse, smoking status, heart enlargement, ECG showing left ventricular hypertrophy, blood glucose levels, and age. So there's nothing that confounds this finding. And lung volume decreased before there was any clinical evidence of congestive heart failure. So lung function decline and congestive heart failure. So more findings from this cohort study. It has been estimated that a 10% decline in FEV1 and FVC is associated with a 28% increase in cardiovascular mortality. So decline in lung function increases cardiovascular mortality. And multiple subsequent studies have shown that low vital capacity increases all-cause mortality, cardiovascular mortality, stroke, myocardial infarction, hypertension, diabetes, future COPD, metabolic syndrome, inflammation-sensitive plasma proteins. So this is the impact of poor lung function. So this is lung function study across the world by Salim Yusuf et al. It's called PURE study. It enrolled a huge cohort of patients, 153,000 patients. And it enrolled subjects, healthy subjects, non-smokers over several continents, including India. They came up with some startling findings. in 2014, that's when the publication happened, they demonstrated that the lung function of the southeastern population was significantly lower than not just the Caucasian population, but almost every other group, even Southeast Asian, East Asian, Sub-Saharan Africa, South America. So compared to all of them, the lung function of the South Asians, and which includes the Indians, was substantially lower. And in India, in 1977, the lung function was 20% lower than the Caucasians. And now in this study, the lung function of the Indians was 35% lower, 35% lower than the Caucasians. Now the Indians perhaps start with a disadvantage straight away in that they have smaller lungs. And what we see as a residual impact, what can happen in potentially a large number of patients, because if the infection infects 65 or 70% of our population, a small fraction incurring lung damage will amount to a large number of people with impaired lung function, and that will translate into catastrophic consequences for the population. Management approach. So in CMC, we have a post-SARI clinic. Any patient with respiratory symptom at that point will have a chest X-ray. Then he will have a lung function test, 6-minute walk test, if they have symptoms, of course, and we would consider echocardiography if they have any features, if they have dyspnea or any features of pulmonary embolism. Then they are referred to the ILD, which is interstitial lung disease, multidisciplinary team meeting for discussion. And at 3 months, again, chest X-ray and lung function is done. If lung function is stable, then we follow them up at 6 months. Essentially, we don't worry too much after that. If there's deterioration, on the other hand, we do CT pulmonary angiogram and again discuss to see how we can improve the outcomes of patients. Now, coming to drug treatment for COVID-19, now we do not have a precedent. We have not treated infectious, post-infectious fibrosis with anything specific. So we have to look at other conditions. So other fibrosing lung condition that is frequently encountered is idiopathic pulmonary fibrosis. So let's look at what we have learned over the years. There is no role for steroids, no role for immunosuppressants, no role for N-acetylcysteine. So we definitely are not going to think about these drugs for post-COVID lung fibrosis. Treat GERD. Okay. So in the case of IPF, GERD is a frequent coexisting condition. So that is treated, of course. If it is there, you will definitely treat it in the situation. Antifibrotics, in particular, pirfenidone and nintedanib, should be considered for these patients. So this is what we have with a similar condition, but can we adopt it without scrutiny? That is the question. So let's look at the data with pirfenidone in idiopathic pulmonary fibrosis. You can see that the lung function decline, which is in placebo, is rapid, but in pirfenidone, it slows down. And the same with progression-free survival. So same thing with pirfenidone. This is a meta-analysis which looks at the decline in lung function with pirfenidone, with nintedanib. Both of them, the odds are significantly beneficial, favoring these two drugs. Both these drugs have excellent benefits in terms of declining, in terms of slowing down decline in lung function. So as we speak, there are several trials ongoing with pirfenidone, with nintedanib in various countries, and we hope also in our country. And we have to wait for the outcome of these studies to be sure whether drug treatments can be offered to post-COVID patients. So in conclusion, COVID-19 causes significant pulmonary infiltrates and fibrosis, resulting in impairment of lung function and exercise capacity. This seems to continue to improve over at least 3 months, and we don't have long-term findings yet. Pulmonary rehabilitation is likely to have a significant role in improving the respiratory recovery of these patients. There is no proven role of pharmacotherapy with steroids or antifibrotics. Hence, active surveillance and follow-up with pulmonary rehabilitation is the way to go. Lung function impairment has significant impact on the longevity of subjects. Information from other studies. Thank you very much for your patience.
Thank you, sir. It was a very lucidly explained the fibrotic thing. And actually everybody knows with the experience of last 1 year that SARS-CoV-2 is not only the viral infection which is going on, but it is a long COVID, it is a COVID sequelae, or even we can call a COVID syndrome. And with all these things, actually, you rightly said the prevention is the best thing. And we are getting the patients now in the OPD basis, in the IPD basis, that patients were having that moderate to severe COVID, and they are continuously on follow on the OPD because of the exertional dyspnea. They are very commonly getting the pneumothoraxis, and even after putting an ICD, the lungs are not getting expand easily. So it is actually frustrating once the fibrosis is done. So therefore the prevention is actually the key of this thing, and very rightly said, sir. Thank you. Thank you very much, sir.
Thank you. Very apt comments. I agree with all that you said.
We don't have any questions, so I think we should go on the next session.
Thank you.
Thank you, sir.
Further move on to the next session, which is very eagerly awaited: COVID-19 vaccination, current options and future strategies. I would like to introduce the moderator, Dr. Ishwar Gilada, who is a consultant at Unison Medicare and Research Center. He has been the past president of AIDS Society of India. He has more than 290 national and international publications, and he has contributed to several textbook chapters. He has received more than 75 awards. I request him to kindly introduce Padma Shri Raman Ganga Khedkar, sir.
Thank you very much, Deveshri. It's indeed a great pleasure to be at this forum. And there are a couple of people in life where you cannot say no, howsoever busy or occupied you are. One of them is my friend Nitin Kadam. Myself, Dr. Nitin Kadam and Raman Ganga Khedkar, we are a product of the same batch from Aurangabad, which is called M75. And we were educated together at the Government Medical College, Aurangabad. Now, introducing Dr. Raman, he is one of the tallest personalities in the field of COVID. And if at all you talk about any viruses, I think if some people are born, they're born for some purpose. And Raman is born for viruses, to take care of viruses and different viruses, Zika virus or H1N1 or SARS or now COVID. He is a chair of the CG Pandit Chair of ICMR at Pune now currently. He was the Senior Deputy Director General of ICMR. He was Director of NARI, National AIDS Research Institute. And we have been associated together since 1975, since we got medical admission. And thereafter, after we passed out, we branched out at different places. I came to Mumbai. Raman was there, he was doing DCH in Aurangabad, and thereafter we never met till almost 1789. And suddenly we met at a CST station where I was putting up the exhibition on HIV AIDS, and then again we are reconnected. So between 81 or 82 to 89, 7 years lull, but 89 onwards, we are connected on day-to-day basis, weekly basis, and we meet often. Except that for last 1.5 year or 1 year or so, we haven't met personally, but virtually we meet often. Dr. Raman is a great authority to talk about COVID and any aspects of COVID, but particularly he is going to speak on different vaccines in COVID. Over to you, Raman. Thank you very much.
Yeah, thank you, Ishwar. I would also thank Nitin to have had given this opportunity to discuss on an issue which is a burning issue. And all of us know we are into a difficult situation as of now, very challenging situation. And where could perhaps in COVID-19 vaccination, where could be the answers that would be lying? We'll try to explore that in today's talk. Now, one of the things which we have to realize is if you look at the most affected countries today in the world, you realize that India tops the whole list. Even it has beaten USA in terms of the most number of cases that occurred on a daily basis. And even the numbers have gone far ahead at this particular point in time. Where is India today? If you look at some of the issues which are very peculiar, is on the if you look at the peak of the first wave and where we are today, it's almost 3.5 folds higher than what was the peak in the first wave. Not a big surprise if it is a second wave. When it comes to daily deaths, then they have exceeded dramatically in a very short period of time, because all of us must recognize that second wave tends to be associated with very high rates of hospitalization. It could be a major challenge for hospital infrastructure and providing care, which we are currently witnessing in India. Now, if you look back, people used to compare, influenza and COVID-19, and we used to say, oh, the mortality is likely to be the same. If you break the mortality into different age groups and try to look at it, you suddenly find the average flu deaths were comparatively far lower compared to deaths. As the years of life, increased, you found that the rates also increased dramatically. It's only when you're looking at less than 18 age group, perhaps you find that both of them tend to become equal. If you look at the spectrum of post-COVID syndrome, now if you heard even Dr. Christopher speaking earlier about pulmonary issues, you find that COVID-19 tends to have a lasting impact. It's almost there. It causes all kinds of issues with different organs, because this is a multisystemic disorder. And by and large, this is a product of dysregulation of immune system. So essentially, you would have affection of multiple. Tend to believe that these tend to occur only among those individuals who have severe COVID disease, but that may not be true. No, the recent papers tend to indicate that even if somebody had a asymptomatic infection, issues like acute ischemic stroke, the risk tended to increase by 2.1 folds, especially among those who were more than 50 years of age. So there is a reason to scare. Are we going to have a burden of people who perhaps could have a lot many morbidities ahead of life affecting their quality of life? What we don't know is whether post-COVID syndrome tends to persist beyond 6 months. How does it impact health or quality of life in the long run? Will it be as common in younger persons compared to what we are seeing among adults who are older? Now, if you look at one issue, the moment people came to know about the first documentation of COVID on December 31st, within 12 days, China shared the first genomic sequence of SARS-CoV-2. And in next 3 days, NIH, which had this mRNA technology with them, they started designing vaccine with Moderna. And Moderna started phase 1 and 2 trials within next 2 months time and published the results within 3 months time. A dramatic thing that one could perhaps look at. If you look at Pfizer started pretty late in the month of May. And then if you look at the outcomes, you suddenly find Pfizer quickly finished it. Perhaps it was a chance event. It was something which was related to the intensity of the outbreak, which was very high in US at that point in time. So the clinical trials could provide the endpoints for assessing the efficacy of this trial in interim analysis pretty early, and therefore their trials ended in November 9, and on December 10th they even got emergency use authorization. Why are we looking at these milestones? Vaccine development occurring within 11 months time was something which was unheard of, but this was possible because of multiple factors including the sustained forms because of HIV and Ebola. Now, if you look at how did this happen, no, scientists across the world, they zeroed on one particular issue, and that is spike protein. The reason why spike protein was picked up was it was an epitope of significance, and also an epitope which a protein which tends to attach to ACE2 receptor and TIMPRESS and try to enter into the host cell. So if you have to have an antibody which doesn't allow it, you will have to produce, you will have to use spike protein and generate that antibody from the host itself. Now, there were 4 different important mechanisms. Earlier, we were producing vaccines. Traditional vaccines were essentially in a different mode. People started using HIV, Ebola experience, and they tried to produce spike protein in a different manner. All of us know that from DNA, which has that entire information which is encoded in the genes, what you do is you try to produce a protein by sending a message through messenger RNA. Now, DNA as an approach, they use DNA to produce spike protein. So there are some DNA vaccines which are also likely to come up. They also used a second approach that was picked up messenger RNA, and then the messenger RNA produces spike protein. They also use subunit vaccine, which essentially means you take the important epitopes of this spike protein and try to bundle them together and provide it as a vaccine instead of giving complete spike protein, whether through putting it artificially or you try to generate it from the body itself. And then whole inactivated virion strategy was also used. This one which we also know a little more is about Covaxin, which is a whole inactivated virion, a traditional old platform. So different mechanisms were essentially used by different manufacturers. Now, where are we with the early interim results? You find Pfizer and Moderna, they used mRNA technology. mRNA is one which is very unstable at room temperature, and therefore it needs specialized temperature requirements. Both these, Pfizer and Moderna, their efficacy was close to about 95%. If you look at AstraZeneca and Sputnik, these 2 vaccines are adenovirus vector-based, and what do we understand by that? They have picked up an adenovirus, which is otherwise a virus that produces common cold, put the gene that was encoding a spike protein, you put it into the adenovirus and try to inject this particular gene through adenovirus into the body of human being. Now, once you do that, it will generate spike protein out of it. What AstraZeneca did was they didn't want to provide an adenovirus to which the body was already exposed, so you have antibodies against it. So what they did was a smart trick. They picked up the adenovirus that was only seen among chimpanzees and no other animal. So essentially, you would not have antibodies already present in the body of a human being. Whereas for Sputnik V, what they did was another smart thing, because these are 2-dose vaccines. So essentially with AstraZeneca, you are going to provide the same virus in both the dosages. Sputnik changed the picture. They used 2 different viruses which are rarely found to be infecting human beings. One was AD26, that is virus 26 in the first, AD5, adenovirus 5, which is given in the second dose, and they had the same technology that you insert a gene that encodes for spike protein. Bharat Biotech and Sinovac, they used inactivated vaccine. But if you actually look at the efficacy is essentially similar. It goes between 80 to 90% among most of these vaccines which we are looking at. What was the effect that these vaccines tend to produce? One was, if you take the vaccine, death is found to be 100% preventable. The second thing which was important is severe COVID perhaps is reduced by 80 to 90%. If you think in terms of effectiveness, perhaps it might drop down a little bit, because most of the figures that you tend to have are from efficacy in clinical controlled setting. But that doesn't tell you complete picture, because these are interim analysis that you are looking at. When it is interim analysis coupled with the background that most of these infections also are going to go for a decline, and then whatever time that you were expected to observe is also going to influence your outcomes of protection figures. So the best way to look at this particular thing is not by percent protection, but number of people who needs to be vaccinated if one case is to occur. These issues will come up later as to which is the best possible vaccine, but the one that comes out as a winner is Pfizer, because Pfizer needs more number of persons to produce one particular case if the persons have been vaccinated compared to rest of them. But is AstraZeneca behind? Not very much. It needs only about 78 people to be vaccinated, and that's something which is important for us to remember. There is no significant difference between Pfizer and AstraZeneca in terms of protection that they can offer. Now, one issue that bothers us is breakthrough infections that can occur if you provide these vaccines. If you look at Pfizer and Moderna that is being provided in US, you find that the breakthrough infection rate essentially means that if I provide vaccine to all, what proportion of persons will actually develop COVID-19 infection if they are going to get exposed by many different ways. Now, if you look at those rates, these rates tend to be less than 1%. These are very small infection rates, far lower than one can imagine. But one question which will come to our mind, what is it that is happening with the two vaccines that we have? Now, if you look at the data that has been generated and being talked of from ICMR, this is on the secondary database that they have. They looked at this and tried to pick up how many people would develop breakthrough infections, especially symptomatic infections, because asymptomatic you cannot catch through secondary data. If you look at Covishield, if you provide only one single dose, the rate of having breakthrough infection was 0.02%, whereas with both the dosages, it was found to be 0.03%. When it comes to Covaxin, it was slightly higher. It was 0.04% in both the dosages that you provide. So essentially, it tells us that whatever we have, our breakthrough infection rates are comparatively lower than symptomatic infection breakthrough rates are comparatively lower. And we expect that these would be competing with the infection rates overall, symptomatic and asymptomatic, with others, and there may not be much of difference between mRNA vaccine and the vaccine which we have. Now, one of the issues is when we talk of vaccine, before we embark on what we need to do, we need to understand that when we think of vaccination, we need to recognize that there is lack of data for pregnant women, lactating women, and children. Now, one of the issues that we need to worry about, if you provide this vaccine and look at the antenatal registry that is developed, global registry that has been developed, you find that almost 14% of the pregnancies are lost if you provide this vaccine during pregnancy. And this is not something which is happening in the first trimester itself. This tends to occur late in the trimesters. Then preterm babies are born in about 10% odd cases. Majority of these children, the 3.2%, are small for gestational age. And there have been records of 2.2% children having major congenital anomalies, but it doesn't appear to be one that is related with COVID-19 vaccine. For lactating women, the question continues to be there. For children, now Pfizer has come up and showed that the Pfizer vaccine can be actually effective right from 12 years to 18 years age group. The other vaccines are likely to generate among pediatric population, including Bharat Biotech's Covaxin. Now, history of severe allergies is one thing which is resulting into anaphylactic shock is another major issue where we need to be careful. But this doesn't mean you would look at the severe allergies of eczema or asthma. They're not counted in that unless there is anaphylactic shock as an issue. Most often, all of us were led to think that herd immunity is likely to be protective to us. And this perhaps was also seen in one of the towns known as Manaus in Brazil, where they looked at blood donors and they found that by October 2020, almost 4/5 of these patients persons, they were already infected, exposed and infected by this COVID virus itself. Now, this had already exceeded herd immunity level. So people thought that it will never come back again in the same population. But there was a surprise in store after 7 months. And if you look at the shocker that came from Manaus, you suddenly realize that there were many different mutants which they detected, because in the second wave, when nothing was expected to happen, you suddenly found that the second wave also was very sharp. It went far ahead than the first wave. And when they looked at those mutations, they found that among these mutations, there was one which is of interest to us, and that is E484K, which is also likely to be an escape mutant, which we have to worry about, because this is a mutant which has also been seen in India. Now, when you think in terms of dosing schedules, excepting for J&J vaccine, which is 1-dose vaccine, the rest of the vaccines are 2-dose vaccines. The interval between two vaccines tend to vary. If it comes to Covishield, it is 6 to 12 weeks, but one has to consider the local outbreak and the need. If the person is older, perhaps you may not wait all that long. When it comes to Covaxin, it's 4 weeks, and for Sputnik V, it is going to be 3 weeks time between two dosages. When it comes to these vaccines, what do they protect us against? They protect us against severe disease. They are actually expected to protect us from mild disease, asymptomatic infection, and secondary transmission, so that the virus doesn't, the person who's carrying this virus will not infect others by having low viral load when they get infected as such. And the current data that tells you about secondary transmission, it says there is a reduction of 30% in secondary transmission. This was specially done among doctors or healthcare workers, those who were vaccinated and those who were not, and they found 30% reduction in incidence that was observed among the families of both of them. Now, if you look at complete protection, that is unlikely to come. The sole reason is, for you need a mucosal immunity, you need IgA, presence of IgA in nasopharyngeal mucosa. This injection is being given intramuscularly, so it is unlikely to generate IgA. So complete protection to prevent transmission is unlikely to be seen. In India, what did we do? We prioritized healthcare workers, frontline workers, and then we went to the persons above 50 years with comorbidity as one of the priority groups. But was that the right thing to do? Perhaps it is also questionable. For one simple reason, we had to perhaps think that if we were going to provide vaccine to healthcare workers, and these healthcare workers who are good at looking at the data would be worried about efficacy, since our trials had not completed, the phase 3 had just begun, and additionally side effects that perhaps one needs to worry about among the people who receive these vaccines, and that led to vaccine hesitancy. Later, the age group was lowered first to 45 years, and now from May 1st, it's going to be 18 years plus who will receive this. And as typically you would see, like you see in the serial Kuch To Gadbad Hai Daya, people started suspecting from healthcare workers and those who were health literates, and they developed vaccine hesitancy. And there was also a contrast that vaccine eagerness was also there among older individuals, but the vaccine was to be delivered to healthcare workers and frontline workers. The result was there was a huge vaccine hesitancy that we had to face in the beginning. Now, when it comes to where we are in terms of vaccine rollout, currently we have provided more than 13 crore dosages of vaccine. Most of it is from AstraZeneca, close to about 11.5 crore dosages come from Serum Institute's Covishield. But if you look at our performance, when we say 13 crores, we stand as number 3 in the world. But the moment you take into consideration the population base and look at that frequency, you find India goes at the bottom, and it looks like a performance that needs to be improved dramatically if we were to think in terms of vaccinating for herd immunity that could come through vaccination itself. Now, one issue that challenged us worse is the mutants that tend to come. And why did these mutants come? If you actually look at SARS-CoV-2, it has transmission dynamics which do not favor development of mutations, mainly because its ability to mutate is slow compared to that with HIV and influenza. Secondly, you need to see that the virus, once it enters in the body, it survives for a period of about 2 weeks time and then dies off itself. So essentially the virus would die and it wouldn't have an opportunity to pass on this particular infection to others. And naturally, we felt that we were surprised that the mutations tend to happen and they occurred at such large frequency that we couldn't believe it. One of the reasons why you don't need to, why we need to worry about it, the reason is when viruses mutate, even if they are RNA viruses, where mutations tend to occur because they have a faulty machinery to reproduce, you must also remember there has to be a selection pressure that could come from antivirals, which are not there in COVID-19, or the immune response that the host tends to generate. Now, given this, there are possibly 3 reasons which we have to worry about. Repeated use of convalescent plasma, where you tend to infuse all different kinds of neutralizing antibodies in different titers, and therefore allow the virus to mutate against the weakest one and try to move ahead. Infection among immunocompromised hosts, because you tend to have longer life for the virus to survive. And what is also important is, since it has error-prone reproductive enzymes, so what will happen is the more opportunity it gets to reproduce or replicate, you will find there will be higher mutations. And this becomes very important even in the current scenario, because if there is a high incidence setting, new and newer mutants are always likely to come out and fight for their own survival as well. Now, what would these mutants do? They can enhance the transmission efficiency, because essentially they want to survive. So they would like to infect as many as possible. It could impact the disease severity. It could make the virus, virus would also not like to kill a human being, mainly because once the human being dies, that's a death sentence for the virus. It can affect the diagnostic tests, because if there are major mutations, then the diagnostic tests may not pick up. If it can affect the protection from natural infection, you could have more reinfections, or also from the vaccines, because these are escape mutants. And it may reduce the utility of monoclonal antibodies, which is being reported from US, that different monoclonal antibodies efficacy is going down in US with the variants that are currently observed. But with respect to disease severity and diagnostic tests, currently we don't see any evidence that is available there in India to suggest that that kind of impact has already occurred. Now, if you look at different variants of concerns, there are currently 6 different variants of concern. Most often we talk of UK variant, South Africa, Brazil, and in US you tend to talk about New York and California. The California and New York tend to have 2 mutations which are also seen in India, and that is E484K as well as L452R. These are present in Indian mutant, which was for some reason they labeled it as double mutant, but there is no such term as double mutant or triple mutant. Actually, there is another mutation that is seen in the spike protein. That is P681R, the significance of which is not known. Most of these mutations tend to be associated with increased transmissibility, and some of them, like the South African and Brazilian variant, are likely to challenge the efficacy and reduce it to a larger extent. And the same may be a fact for the Indian variant that we are currently looking at. Immune evasion is likely to occur with the Indian variant that we are seeing at this point in time. Now, do these vaccines work against newer mutants? When it comes to South African mutant, which is considered as the most difficult one to handle, you find that the vaccine's efficacy tends to drop by almost 40% when it comes to these mutants being present in the population at that juncture, whether it is Novavax or Johnson & Johnson. Now, one of the issues which we must remember, that if you look at PRNT, PRNT 50 actually tells you the ability of your own neutralizing antibodies to neutralize the viral strain, you find that the antibody neutralization tends to become weaker, no, when it comes to, tends to become weaker if you have, no, variants which are present, and that affects received vaccine and is protected. Vaccine appears to be better protection compared to natural COVID. About Indian mutant, when you look at E484 case data, you find that neutralization assays tend to suggest that this could perhaps be an escape mutant because it requires more dilution to actually inhibit the replication in PRNT50. Now, the implication of development of rapidly transmitted variants. One must remember the first implication was initially, we used to think that if somebody has a herd immunity, a country has, or an area has between 58 to 74%, perhaps we may be in a position to eliminate this particular infection rapidly, given that you are also going to use the COVID appropriate behavior. But if you look at the current variants that are coming, reducing vaccine efficacy, the whole thing has changed. Now, what it actually means is two things for implementation. One is rapid scale up of vaccine coverage, and second, herd immunity is more likely to kick in when your coverage rates go beyond 90%. And that's a tough ask for a country as large as ours. So what exactly would I be trying to tell? One thing is, we tended to look at number of people who are exposed to, proportion of people exposed to this particular infection, looking at seroprevalence surveys, and we felt we were coming close to it. That cannot happen. It's like a mirage. No, because if you find that the person has antibodies against the wild strain that we had, and the virus is mutating, you find that there would be some population which would continue to remain vulnerable for these escape mutants. So it's something which will keep on increasing the goal. And what is important is, if a country tends to take a very long time to achieve vaccine induced herd immunity, the challenge would be this mirage will continue for a very long period of time, because new and newer variants would be generated against. So where are we in terms of rapid scale up? If you look at the rest of the world, the developed world, you find that USA and UK are fairly well. They are likely to have achieved herd immunity within next 6 months time. USA perhaps will achieve it in next 3 months time itself. But when it comes to India, we would require 2 years time. Look at the other countries, Russia, Sri Lanka, they might require close to about 10 years time. Now, if this is the way, one must remember that this is an infectious disease which disregards the geographic boundaries, because you cannot stop. If there is another one country which has this particular infection growing in that area, you will find other countries will also get affected and the infection can hit back again. How long does this is also added by another factor, that is, how long will the protection last from COVID vaccines? We still do not have robust data, but we know for sure that it may last for a period which could be around 11 months. Perhaps it appears as of now from the evidences that are getting generated that annual vaccine boosters may be required that would cover the newer variants in future. Now, where are we? As we said, currently deaths and hospitalization remains as a major issue in the second wave. Now, how do we handle this second wave now? One, you could go for calibrated lockdowns, because lockdown does not serve. Complete national lockdown is unlikely to serve any purpose whatsoever at this point in time. We cannot compare ourselves with the smaller European countries and try to think that lockdown can be beneficial. The first lockdown had a different measure, that we wanted to do it to prevent entry of this virus in the country. Now that it is there everywhere, you will have to essentially go for calibrated lockdown, which balances the health and economic outcomes really well. 95% people need to adhere to COVID appropriate behavior, and we need to provide vaccines to all who are above 45 years as a priority, and those between 18 to 45 subsequently. The million-dollar question is, we have missed the bus of 3 months when there was a decline in infection that we had. Perhaps we could have had used this opportunity to vaccinate all, but we couldn't do it mainly because of vaccine hesitancy that we had to face across. Now what do? We need to mobilize community, bring vaccine eagerness, and first saturate 45 years plus population. But the complete protection tends to come after 42 days of the first dose, because these are 2-dose vaccines. So there is a worry that most often we would have. But what do we see here in terms of evidences? You find that mRNA vaccines tend to be highly effective within 10 days itself after the first dose. And there was a time when people used to ask a question, why do we need to give 2 dosages for mRNA vaccine? Because the protection is higher right after the about 12 days after inoculation of this particular vaccine. If you look at vaccine efficacy after first dose for AstraZeneca, it tends to come after 22 days of the first dose, and the person tends to be protected to a larger extent. Now the issue that tends to come is the certain countries had to play with that particular information, like UK. When they were facing the third wave, which was as bad as our wave, considering the fact that their population size is smaller, naturally their hospitals numbers of beds is also going to be as small. So they had to fight the war in a different way. So what they did was they tried to give first dose to as many as possible, mainly because the number of dosages that are available world over are limited. So they decided that all those who are old, first they would be targeted, those who are 80 plus, and then subsequently we will go to younger population. And what does it show? That when they started this with only first dose, they decided first dose will be given to all of them. You look at the impact, you find that not only the cases, the hospital admissions and deaths were found to be higher in a population between 18 to 69 years age group compared to those who were 80 years plus at that juncture. And that's something which tells you that this strategy works. Even if there is a first dose, you can make a huge difference. The reason why we are talking about it is, we, including myself, used to believe for quite some time that provision of only one dose or provision of vaccine may not help much, mainly because you are going to require longer time to control in the second wave. The protection will come late, but that doesn't appear to be true even with this particular data that you get from UK. And if you actually explore furthermore, the UK's data tends to tell you that this decline actually has been higher with the age groups in which the individual belongs. No, even one dose goes for dramatic reduction in mortality among these people. The cases that tends to get reduced, and both tend to be seen even among the oldest of the population, and younger ones, you find that it tends to get reduced over a period of time. So essentially, it's highly impactful. It's something which can prevent deaths. Now, the same thing was done by Israel, which was the first country to completely cover their population with the vaccine that was provided by Pfizer. And when they looked at their own data, what did it show? Not only there is a decline in the number of cases, but the new hospitalizations, they found sudden departure. They also went with age prioritization. They provided it first to older population that was 80 plus. And what did you find? That when that started happening, more of hospitalization was seen in younger age groups compared to the older ones. And naturally, development of severe disease was far more lesser in older age groups compared to younger ones. Now, the prioritized approach to vaccinate, if you look at the impact that it had in USA, you find that if you compare the fall that tends to happen, the fall in USA was registered to happen a little slowly. And what is important is there was a vaccine effect, but the infection was commonly detected in those times among most of the people who belong to younger age group as well. Now, this is something which is something which is a challenge that we would have to face. But two variants that are being detected, L452R and E484Q, Q and K are almost similar kind of mutations that you are seeing. And if you look at the data that tends to come from Maharashtra, almost 2/3 of the samples that were collected for genomic sequencing had mutants, and majority of the district, excepting Bombay, they had high proportion of mutations that were occurring, that were being seen. Now, you need to go for a rapid rollout of vaccine. Now, one of the things that we worry is we have a severe second wave. Would we be able to see similar impact that has been seen elsewhere in the world? You look at UK data on the left side, you look at US data, you find that the vaccine effect actually is higher where the incidence tends to be high. And if you go by the latest among the whole lot, that is Chile, where the wave was extremely severe, the third or fourth wave was very severe, you find the vaccine impact is far more higher. So there is a hope that even if we begin today in the second wave to try and saturate the population 45 plus years age group with vaccines, perhaps we will not have similar kind of mortality that we are seeing today. There are newer vaccines which we will have to produce to chase the escape mutants. Now, these are first generation vaccines which we are using. It doesn't produce sterilizing immunity. Continuously, these manufacturers are also undertaking smart genomic surveillance. And if you look at the time that each of these companies will require to produce, the data tends to come from mRNA vaccines. You suddenly find that the time that you require to produce a new vaccine dose is far shorter. It ranges between 2 to 4 months time. And that's something which is a good feature that we have to keep at the back of mind. For companies like Bharat Biotech, perhaps one of the things which we have to think about is they may require a period which could be around 3 months time since they use the whole inactivated virus particle. But there is another worry. If you are going to roll out the vaccines, you do it in India, and there are countries which are also connected. This is a global village, and there are countries which are not immunized. You find that the world will be divided into two: those who are immunized and those who are not. Partially immunized world can put up a pressure on the virus to mutate more, and therefore there could be a surge of outbreak even in areas where partial vaccine induced immunity will not be able to stop this infection from growing. And that's one worry that we have to worry about. The virus tends to become endemic. What is the final future? The final future could be, we need to remember that the immunity that is offered by whether by vaccine or natural infection is going to be less than 2 years time. New escape mutants are going to continue to come up, and they will foster this infection and let this infection become endemic. Now, when this starts happening, we have to remember that they start infecting the younger age group. You will find that the preponderance of infection would keep on going towards younger age group population rather than older population, and then the infection tends to become endemic. Now, how will we handle this younger population? One of the things which we have to remember is today you don't allow schools. It appears that schools to be reopened is going to be one major challenge that we will have to face with respect to going physically to the schools. But if you look at, do we need to be very cautious in our approach? If you look at the likelihood of death, whether COVID is in the top 5 conditions by age groups, you will find the older you are, you would have that red bar higher up because it would be number 2, number 3, number 5. And then when it comes to younger age group, that is age group of 1 to 17, perhaps the risk of death would be lower. But can we use this logic and let children do whatever they want and cover only the 18 years plus population? Perhaps not. It's very difficult to decide because we do not know as of now what would be the long-term impact of infections in pediatric population. Now, when we tend to vaccinate, we will have to continue following COVID appropriate behavior subsequently. The reason is the best defense against emerging variants continues to be COVID appropriate behavior. They would protect you by 85% if you actually use COVID appropriate behavior. What is also important for us to remember that shedding of virus in asymptomatic individuals is likely to occur. And that becomes very important for one simple reason that, majority of these people, those who are vaccinated may have mild and asymptomatic infection, and that would lead to transmission. And there are other non-respiratory benefits that would come with respect to use of COVID appropriate behavior. Now, what is also important for us to understand is when you open up, we will have to be cautious, learn from other countries as to how they are opening up. And this becomes important for different countries. They are trying to use this particular opportunity to learn about mobility. And that's an important issue for us to understand. Is there a light at the end of the tunnel? Yes, there is. We need to be aggressively going to go for vaccine rollout in prioritized population. Over 220 second generation vaccines are being developed, and people are trying to develop effective drugs against this particular virus. Together, even if we adhere to COVID appropriate behavior and also take vaccines if you are eligible, we may still be able to reverse this second wave quickly. What is most important is we have to trust we are human beings, far smarter, and we will adopt new behavior. There is also a light at the other end that newer vaccines are going to come, which would add to the capacity and may provide more dosages to us. Novavax is going to come. This is a protein subunit vaccine. ZyCoV-D, which is a Cadilus DNA vaccine. J&J is adenovirus-based vaccine. Bharat Biotech is trying to produce nasal vaccine, which should have better ability to protect us from infection. And Primas Biotech is also trying to produce an oral vaccine, which is also trying to go for a trial among human beings at this time. Ideally, what do we need? We need an effective drug discovery. To add to COVID appropriate behavior and vaccines in your armamentarium, if you get an effective drug, we can perhaps eliminate this infection quickly. Unfortunately, the drug discovery program needs a huge support, because when you have vaccines, their market size is likely to become less smaller, and therefore you need to provide funding through government sources for them to actually ensure that drug discovery program goes on well. If we do this all of us are older, perhaps we need to think little differently for future generation. The only hope that these children who act almost as if they are imprisoned in their own houses, when they look outside their own windows, they cannot go out and play with their peers. They can't go to garden. They can't go to school. The future tends to look bleak for them. But if we all work together, try to ensure that everybody takes vaccine, we try to promote vaccine to patients, people who ask us, perhaps we will be able to make difference in terms of these children and their future. Thank you.
Thank you, Raman. We end up being wiser than what we were about half an hour, 1 hour back. We understand the importance of vaccine, and therefore it is virus or the vaccine, choice is yours. If you look at COVID appropriate behavior, we need to the east. We need to look at the east, and for the vaccine, we need to look at the west. So we are in between. And what we should have learned from the mistakes or success of other countries, we did not. So second wave is much more fast, and probably it is going to be much more worst in coming days. We can see up to 500,000 cases every day. It may not go beyond that, because we are not going to test more than 20 million a day. So in that kind of situation, we need to use this current wave to educate people that you are expecting the whole world to be shut down. You shut down your mouth, you mask up properly. If that is not possible, then we are going to have this kind of issues. And secondly, what current issues we are facing is an oxygen shortage. We have never seen some people are dying for want of oxygen or for want of drinking water. So this kind of situation is worst to come. And again, that can be used to educate people that, look, that should not happen. In HIV days, we have what we've seen about 30 years before in Africa, that one oxygen cylinder shared by 7 children lying on 2 different stretchers. And we used to show that picture to India or in education program, that let us not repeat this scenario. Same thing has come today, that oxygen shortage should be used as educative tool to tell people that only 2 things which can save: one is masking and second is oxygen and vaccine. And secondly, what we can also tell people, that if you vaccinate today, you're not going to save your people from second wave, from third wave. So, and I agree with everything what Ganga said, Raman said, but not the vaccine hesitancy has not slowed down the vaccination. Vaccine hesitancy was there. There are vaxxers, there are dissenters who will say there's nothing like HIV, there's nothing like virus. It's created by researchers and doctors or pharma companies. But despite that, there was a short supply of vaccine, and still there is a short supply of vaccine. So there is somewhere we need to look at. If we don't have to have this same chain again repeating, we need to complete vaccination within 10 to 11 months. If we don't do that, we'll have to have second round of vaccine, third round of vaccine, and probably we need to look at how we can augment that. With this, I would like to open up for questions. If you have how much time, I don't know how much time you have. Diveshri, we have some time for questions.
We don't have much time.
Yeah, I have only see 2 questions in the chat box.
Okay.
One is a very important question. Where is, 1 minute. I cannot see the question vanish. Where were the questions?
So one of the most common questions that we are asked is, once a person gets COVID in between 2 doses of vaccine, when is the earliest that they should be taking the vaccine?
Yeah, ideally, one of the issues that we have to remember is when you produce antibodies against the infection, and if I take vaccine, if I take adenovirus vaccine or even the vaccine which is provided by Covaxin, now what will happen is the take of that vaccine is going to get affected. So what you need to wait for is whatever the natural antibodies are produced, they must get degraded to a larger proportion. Now, when does that happen? Ideally, it happens after 12 weeks, because the half-life of these IgG antibodies, you consider, which are considered important in terms of takes, that would become very critical.
There's one more question, Raman. Please comment on role of vaccination in IgG reactive or recovered COVID-19 cases.
What is that?
Comment on role of vaccination in IgG reactive, that is recovered COVID-19 cases.
Yeah, that is what I said.
Yeah. And there is one more is, can you share worldwide data on number of COVID deaths despite 2 doses of vaccines?
Despite 2 dosages of vaccine. Yeah, as yet, no, let me put it the other way. No, it is very difficult to talk about what is happening in India. What is more important is you will have to restrict yourself to the Western world, except in UK, where AstraZeneca vaccine is widely utilized. It's so much in Europe and also in USA. It is still not approved. The result comes to vaccines which are given as mRNA vaccines. We know it doesn't affect. No, you don't.
I think there is a connectivity issue. Should we end it here?
Associated with vaccine.
Yeah. Okay, got it. Okay, thank you very much, Raman.
So there's one more question. Like right now we are facing a second wave, and government, I think they have made a change in their policy regarding the second dose. So do you think we should roll back to, earlier vaccination, take it like post 4 weeks, or rather than, waiting for 6 to 12 weeks? Or you feel the single dose vaccination for large number of people is a better option?
One thing that I would put it in a different way. India should not have sports to occur as easily. Number 2, if the vaccine dosages are adequate, I would prefer that the second dose is given to those who are eligible. Now, with respect to that publication of providing vaccine later, the second dose later, actually is beneficial. I have my own personal views. I cannot speak on behalf of Government of India or ICMR. I think what is more important for us to remember is, especially in the second wave that we are seeing, if the person is older, no, it is better to give the second dose earlier rather than taking a small chance. Perhaps, even if they don't develop so much of antibody, it doesn't matter because you want to protect them from death. So it depends on the level of outbreak where the person is staying, and also the fact that the age of that person would be important.
And there's also a trend towards checking the antibody post vaccination. It's like, it's very difficult for us to handle. Almost everyone does it after first dose, after second dose, 1 month after the first dose. So, any comments on this?
Ideally, let us remember one thing, that we do not know the correlates of protection of this vaccine. No, we don't know at what level the antibody is going to make a difference. There is only one study that has been done in animals where they found that anti-RBD ELISA, if it is more than 137 folds higher, then in those cases you can call the animal to be protected. But you cannot pick up those findings and apply to human beings straight away. Now, when people are doing anti-RBD assay or even IgG assay, does that tell you enough? No. When you don't know what is the sensitivity and specificity of this particular test to show what is the level of protection, there is no point in doing that. The only thing which may become important is, we know the older generation is more likely to be vaccine non-responder, because vaccine non-response tends to increase with age. So if they find that something is not there, we may still have to wait for an answer coming through different studies. We may have to provide either a different vaccine using different platform to ensure that non-response is countered, or we may have to provide a third dose to such people. But we don't have clarity on that as of now.
Very much, sir. Thank you, Raman sir. Thank you, Ishwar sir.
Thank you.
Now we'll head towards the question and answer session with the experts. We don't have much time, but I think we'll try to take 2 or 3 questions. So my first question will be to Priscilla ma'am and Valsan Varghese sir. This study was published in Lancet regarding airborne transmission of COVID-19. So based on this, have your policies changed?
So, Divya, thank you for the question. See, WHO's official policy is that we need only droplet and contact precautions. There has been reports, I'm sure you've heard about the Australian report and the China report, where they suggested that there might be airborne transmission in a closed area with no ventilation. So in that case, we know that the aerosols actually remain in the air for a while, and those are the ones which can probably potentiate transmission. But in a healthcare environment, I think we do know where there is aerosol generation continuously happening, and that's usually the intensive care settings because of nebulizers or ventilators and etc. So in those cases, yes, there is a potential of airborne transmission there. But in a normal a household with good ventilation, windows open, fans on, and people at a distance of 1 meter or more, I think the chance of transmission through air is negligible. So I would say that we have to look out for situations where airborne transmission can happen, and that usually happens only in closed environments with poor ventilation, with people who are not following PPE precautions, and basically speaking or singing very close together. So those are the only situations. So no, we have not changed our policy.
Sir, you have anything to add to this?
I would just add one thing.
Sure, sir.
There is no reason for us to get scared. No, perhaps this is going to create a scare in the minds of healthcare workers more often. Even the lay persons who are perhaps affected the worst way. There is no reason for panic. Now, all of us must know that both the routes of transmission were already known. Now, when we talked of droplet transmission, and then we were talking in terms of aerosol related transmission. It is just that they are saying at present the droplet infections are not considered equal to airborne infections that could occur. But that is in a setting where there is poor ventilation, where at household level, all of us know in the household, the transmission is more likely to happen because COVID appropriate behaviors are not followed. Most often the message that we are passing is it's more like a pollution, no? Like you have the particulate matter that is floating in air. People tend to get worried whether the virus is also floating in the air. No, it is not true. What we have to do is try to ensure that panic doesn't set in. The modes of transmission continue to be same, and this is not a Lancet study. This is not a research study. They have collated data from different studies and come up with a hypothesis. So how much of it should be accepted? It continues to remain a question mark. Is aerosol the same? Otherwise, all doctors could perhaps have been infected by now.
Yeah, thank you, sir. I really wanted insights on this because there's a lot of scare among the doctors. There's a lot of anxiety. So I think your words are definitely going to be extremely reassuring. I think we have had enough explanation about how different COVID wave 1 has been and COVID wave 2 has been. So I just wanted to share that in Mumbai, we are seeing a lot more younger patients, a lot of them presenting with longer complaints and younger patients who are going on ventilator. So I just wanted to know if in your side of like from Vellore or even other places, if you have much more information regarding this, regarding younger patients.
So I can speak for Vellore, or Dr. Vijay and Watson can also weigh in. So we are just about in the upslope of our wave. So we haven't really plateaued yet, nor are we in the downslope. Are we seeing younger people? Yes, we are seeing a few younger people who have prolonged fevers, who are going on to becoming ventilated. At this point in time, we don't know whether, we don't know the exact numbers as to whether they're different from what we saw previously. So we can't say for sure at this point in time, but yes, it does seem to be the trend.
And there are a lot of patients who are just having persisting fever beyond the first week of illness, who are not actually becoming hypoxic also. So are you employing this strategy of using steroids in them?
So, that's a controversial thing. I think, see, the thing is the basic reason why we employ steroids is to reduce inflammation, isn't it? So fever is a surrogate marker. What we have done is we've left it to the clinician to judge. We don't really recommend steroids when they're not on oxygen. But what we are doing is actually doing an exertional desaturation test. So in the ward, either a 6-minute or a 40-step or a 1-minute sit and stand, and checking if there is an exertional desaturation, and at that point in instituting steroids. Anybody beyond a fever beyond 7 days, we are actually doing an imaging. If the CT scan is showing an interstitial pneumonia, we are going ahead and then instituting steroids. So this is what we are following. We are hesitant to use steroids widely. So this is the strategy that we are employing right now.
Just to add to what Priscilla said, as far as pediatric numbers go, we have not yet seen, a different, we've just seen an upslope. We have not actually seen more numbers, but it's early days yet, so we'll see.
And what is your strategy regarding the use of remdesivir in adult patients, Priscilla ma'am? Because one thing is we are faced with severe shortage, and second thing is actually WHO has it has has
So
yeah.
yeah, so yeah, you're right. WHO has actually said that remdesivir is not recommended. And I think we have to be clear as to what is the most benefit. So the way we classify most benefit is based on mortality. Is there a mortality reduction? And we know that remdesivir does not produce a mortality reduction. And that's the reason why WHO has kind of downgraded it. Now, if you look at the various trials that have reported a role for remdesivir, it's actually only the ACTT one which has actually reported that there is a subset who benefit from remdesivir before they become severely ill or critically ill. So people who go on to, so our strategy is people who go on to oxygen, immediately they get remdesivir. We no longer give it in severe or critical. We say consider, and it is left to the clinician to judge whether or not to actually give it. So what is recommended for us is actually in the moderate situation, in the moderately ill patients, we would like to give remdesivir to shorten the duration of hospitalization. That is our basic aim. We know it does not have a mortality benefit. So that is the group of patients that we are targeting to give remdesivir.
ICMR has actually come out with recommendations on remdesivir, which are pretty much the same as of today.
And what is the take on current take on tocilizumab? Because initially when it came, it was like everyone wanted to receive tocilizumab, especially the ones who went on to need oxygen, worsening oxygenation patients.
Okay, so as part of our COVID management guidelines group, as you know, we actually have an evidence synthesis team who's looking at it, and we're hoping to come out with a guideline maybe the week after. So we've actually looked at all the trials which have reported an outcome of mortality for tocilizumab. And if you actually look at all the trials, the ones with the largest number of patients is actually the REMAP-CAP, and the second one is recovery. So only if the major part, if you actually look at the Cochrane review was just published recently, and if you look at the COVID NMA guidance, which is updated weekly, you will see that actually these two studies are the ones which skew it towards the side of benefit. So if you look at the inclusion criteria for both of these studies, they basically include anybody who has a fractional or other FiO2 of more than 40, anybody who's on more than 30 liters of oxygen, anybody who's requiring non-invasive or invasive ventilation, along with a marker of systemic inflammation. So a CRP, which is more than 75 or more than 100. So based on this, actually, we've just changed our guideline yesterday, and we are saying anybody who goes on to NIV or invasive mechanical ventilation, or who with a CRP level which is more than 100, we would like to consider tocilizumab. I think it's very important to remember that it is an expensive drug. We have to be very responsible with the way you use it. There has to be definitely a subset of patients which has to be identified, which benefit from it. I think that is very important. It cannot be used irresponsibly. It is a drug that has shown to reactivate many kinds of infections. And we are seeing so many secondary bacterial and fungal infections. So we have to be really, really careful, especially in our country where there is so much TB and other infections around. So that is what is my take on.
Balsan sir, Christopher sir, you would like to add anything to this?
Maybe I'll just a point on each. I think there is this concept that giving something is better than giving nothing. So everybody tends to want to give something, even if the evidence for that is not good. For example, giving steroids in mild cases. Actually, recovery study shows that it is deleterious to give steroids in a subgroup that are mild cases. So what we do not take cognizance is the fact that sometimes the treatment can actually worsen the outcome. So we should be cautious about using the medication in the right time, in the right setting. Same goes with remdesivir. So because there's a shortage, I won't panic since the mortality benefits are not there. So perhaps we could use it, but we won't lose sleep over not having remdesivir. Tocilizumab, I think, is useful in a subpopulation. We should be carefully selected.
No, but if you look at the recent study that is published in NEJM, it goes completely against its use even in severe COVID disease. And nationally also, we have taken the same stance while looking at those guidelines as to what should be given to the patients. I think it is important to remember that there would be two things. You may use agents which you think may help, but at the same time, the outcomes, if they are unproven, and the fact that they are also not available so easily and the cost is prohibitive, you might leave behind the scars in the family. Since it must be somebody's father, he will feel, if I would have had procured somehow TCZ, I would have made difference. I think what we are eventually going to have is a society with PTSD to handle for some time.
The trial that you're referring to is the COVACTA trial, which only has 452 patients. Recovery and REMAP-CAP actually have more than 1,000 patients. Recovery has 2,022 patients who are on the tocilizumab arm. But you're quite right. I think nothing is a magic solution. And tocilizumab has, if you look at it, you're absolutely right. You look at the absolute risk reduction, it is anywhere from 2% to 11% as an additive effect to steroids. So if you look at the list, if you look at the way the evidence has actually come out, so it is 2 to 11% additive effect to steroids. So you're quite right. It should be taken, it should be used responsibly in that sense. But REMAP-CAP and both recovery, who have more than 2,000 patients, actually have shown, REMAP-CAP has 1,000 something, but recovery has 2,000. And they have shown a mortality benefit, but I agree, it is not dramatic. You have about 32 fewer infections if you actually use it. So you're quite right.
Virafin, it is the new kid on the block, and it's all over the news, all over WhatsApp, and we have been flooded with a lot of calls about our take on it. So I think I would like to hear from all the experts what is their take on Virafin. And you would like to start?
I was hoping somebody else would start. Okay, so I mean, I think nowadays we don't hear about drugs from actual journals, right? You hear it from media, you hear it from WhatsApp. Okay, so now that's the go-to information source, unfortunately. So, I mean, we all know interferons are antivirals. I mean, that is something that has been known for generations. But with regard to interferon alpha 2b, right now, the results that have been reported is the phase 2 results. I'm not sure, just, studying it in 20 patients is enough for us to say that this is okay to use in patients. I know, and their primary outcome was not really mortality. So I'm not really excited about this at this point in time. I would reserve my comments on it. The biggest trial which has actually looked at it is actually the WHO Solidarity trial. There, they very clearly demonstrated that there was no effect, no mortality benefit, no symptom improvement, nothing. Do we need treatments? Of course we do, but then I think it's important to weigh benefits very carefully. We have to await the phase 3 trials and put all the trials together, glean the data, do a data extraction, run a meta-analysis, and make sure that we're on the right track. Because this is an expensive drug. So we need to, again, make sure that we are doing the right thing. So right now, if you ask me, am I going to include it? No, not in my treatment guidelines, no.
Very sketchy evidence.
Christopher, sir, you would like to add anything to that?
Yeah, I was saying that, as Priscilla said, The evidence as we have it is very flimsy. And it has not reached the stage of trials where you consider incorporating into treatment algorithms. So I think we should watch and not go by the media promulgation of efficacy.
I just wanted to add something. PEG interferon and ribavirin have been used for hepatitis C, and they've actually been, supplemented by antivirals. They are not exactly without side effects, and they are expensive. So like Priscilla said, without more evidence, we'll see.
I think there's one last question from our nephrologist. Should we start patients who have received tocilizumab in high-risk patients like post-renal transplant, empiric antifungal therapy?
The short answer is no.
Yeah.
We don't have evidence.
Yeah.
So no, I don't think so. But we don't have data. Let's put it that way.
Yeah, and especially with the amount of reports of fungal infections, starting someone on prophylactic antifungal therapy is just going to give rise to resistant fungal infections. So again, the answer is no.
So some of these questions.
I would just say one thing, it is time we go back to evidence-based medicine, which we used to follow in pre-COVID era.
Yes, sir.
There
Yes.
cannot be 1 or 2 patients trials, where people tend to use it as an experimental thing as if it's a clinical trial. Doesn't make sense. If I'm one of those who believes that accepting steroid, what is emerging very strongly is a good quality supportive care, which becomes far more important compared to rest of the interventions if you take out steroid. No, rest of the places there is no data. If there is no data, we have no reason to state that truthfully to the patient. No, I keep on telling in the National Task Force, in the clinical TRGs as well, that in HIV we lived without drugs almost for perhaps 7 or 8 years, as I remembered. We never told them that you can take X drug or hydroxychloroquine. There, that time also hydroxychloroquine was touted as one drug which can work. But we need to be careful. We need to, because these are false hopes, and that can create far more problems.
Sure. I think we'll end this question and answer session. I will request our medical superintendent, Dr. Kalyani Sen, to deliver the vote of thanks.
I begin, I would like to, on behalf of MGM and my MGM Institute of Health Sciences and MGM New Bombay Hospital, Ranchi, I express my heartfelt thanks to each one of you who has participated in this. I'm sure everybody found it very informative and worthwhile. But before there were quite a few take-home messages, and especially the Q&A session was really interesting. Dr. Priscilla Vipali started the series of presentations, and with the best message that being well prepared is the best defense, probably. But the question is, how well are we prepared? How well is our infrastructure? How much have we learned? But yeah, I really was impressed by the way the CMC Vellore Bioengineering department did those moderated and made those changes to the infrastructure. Then having their own oxygen generation in campus must have really been a great thing. And that is what we are seeing all over the country, like facing oxygen shortage. It was indeed a very nice talk, Dr. Rupali. Thank you so much. And, Dr. Abrahams, the take-home message was we should be avoiding unwanted antibiotics, antifungals, and steroids in stable patients. That was, I took that as his take-home message. Thank you very much, sir, for giving your time. Dr. Hegde's, he deliberated on various aspects of weaning which need to be addressed. And he discussed the several approaches on difficult weaning. And the key message was prevention of secondary infection is the key in ventilated patients if we have to avoid weaning difficulties. Thank you very much, Dr. Balsan Varghese. The presentation of atypical cases, to vaccination in the pediatric population, and inflammatory syndrome. The takeaway from your talk I see is that there is no evidence of the use of remdesivir and all in pediatric population, and you underline the fact that supportive management is the mainstay of treating pediatric cases. It was indeed very interesting because all along everybody's talking about adult COVID, and it was really nice, refreshing to hear about the pediatric COVID patients. And you also underlined the importance of masking for children. The next was Dr. Christopher, who gave a very, very interesting and detailed presentation of the sequelae of COVID and how to do a respiratory follow-up of the patient, what is the, how it should be planned. And the take-home message, what I take from his talk is the importance of pulmonary rehabilitation and early initiation of pulmonary rehabilitation. And I think after that, I think Dr. Raman sir came in, and his topic was very, very interesting. And many interesting questions were answered through his talks, like how the mutants develop, the impact of the mutants, and the transmissibility. Do the vaccines work against the mutants, and need to rapid coverage of the population by the vaccines was important. How long will be the effect of the vaccine was a question which is in everybody's mind. What should be the spacing between vaccines? All those questions were taken, answered extremely well. And one take-home message is from your talks is a need for rapid rollout of vaccine. And we need to saturate more people with vaccination to reduce mutants. And a partially immunized world can put pressure on the virus to mutate more. And the best part was the ending where you said there is a light at the end of the tunnel, which is with vaccination and COVID appropriate behavior. So a lot of people have participated. Thank you very much to all the participants. Then our dynamic speakers and panelists provided a lot of insights which were actionable, practical, and the Q&A session covered a lot of queries and answered our queries. And thank you so much, because all of you all have been so busy with your handling the situation. And Raman sir has been part of the task force, and everybody else are busy clinicians. So we really, really appreciate your involvement in this CME, which was, and we wish to have many more such events in future. And as we all know, the current pandemic has all been about adapting and innovating. And thank you very much. This has been one of the most informative CMEs on COVID-19, and hearing all the eminent speakers who have been policymakers
It was indeed enriching for all of us. I'm sure all the participants have gained a lot hearing you. And a big thanks to Padma Shri Dr. Raman sir, Professor Dr. Priscilla Rupali, Professor O.C. Abraham, Professor Walson Burgess, Professor Dr. Ashit Hegde, Professor B.G. Christopher, Dr. Gilada, and all the moderators. And here I would not, I would fail if I didn't thank our team here at MGM IHS and at MGM Vashi, Dr. Divyashree for organizing the entire thing, Dr. Archana, Dr. Tushar, who along with their clinical work took time to arrange this excellent CME. Thank you very much and wish us all pandemic-free better times when we can meet again and discuss what happened. And I hope the worst gets over soon. Thank you and have a very great evening.
Thank you, everyone. It was an honor, and we wish we could have been of more help, but it's still, to do this during a pandemic is a really great achievement on the side of the organizers. Thank you very much.
Thank you.